Hello everyone, welcome to the class. Myself, Dr. Vaibhav Jain, and let me know if I am clearly audible and visible so that we can start our session. Let me know in the chat box, guys, whether I am clearly audible and visible. Your exam is so nearby. We are conducting sessions, rapid revision sessions, so that would be helpful for you guys. So just try to attend all the sessions and let me know so that we can start. All right, guys. So today we are going to start our subject of dermatology. In dermatology, we are going to do all the important topics, all the previous year topics that has been coming up in your examination. So we will be discussing about all those things. Okay. So be with me till the end of the session, and we are going to get approximately 5 to 7 marks from this class, right? So this is very important. Now let's see how we are going to proceed. We are going to do all the topics. So first of all, we will start with the basics of dermatology. In basics, what we are going to do, we are going to see all the structures. Okay, then we are going to do the skin appendages. Okay, in skin appendages, guys, we are going to study about the क्या क्या चीज़ें होती है. That is your nails, that is your hairs. Okay, that is your glands in the skin appendages part. Then we are going to study about the papillosquamous disorders. That would be incorporating your lichen planus, your psoriasis. Okay, then we are going to move on to infections. In infections, we are going to see all the bacterial, viral, fungal, and your parasitic infections that are important for your examinations, right? After that, we are going to look for the STDs. What are different kind of STDs, right? And all the STD kits, because the question is coming from integrated part also, so we will be covering in the integrated manner, right? Next thing, we are going to see about the vesicobullous disorders. That would be vesicobullous disorders is basically there will be vesicular disorders and there will be bulla. Okay, so we will be studying about the all the pemphigus group of disorders, pemphigus, pemphigoid, all those things, right? And then we are going to study about the pigmentary disorders. In pigmentary disorders, we are going to see all the hypopigmentation disorders and hyperpigmentation disorder, right? So all the hypo and hyperpigmentation disorders we will be studying here, and then we are going to end up with the certain miscellaneous topics. Okay, certain miscellaneous topics that has been asked in your examinations. Okay, so this is how we are going to start, and please try to be proactive. Please try to answer in the comment section. Okay, so that that would be helpful for you. Okay, so now let's start. The first thing will be, we are going to start from the basics. Okay, if you have done your dermatology, well and good. अगर नहीं भी पढ़ा है तो भी कोई बात नहीं है. Okay, the session will be in Hindi as well as in English. Okay, so we will be covering everything, right? So if you have not done your dermatology, no problem, we will be covering everything. Okay, so first thing, what is the anatomy of skin? Okay, we will start with the anatomy. So just tell me, guys, what is the largest organ in the body? Okay, what is the largest organ in the body? Largest organ of the body. Answer me, guys. The largest organ of the body is skin. Okay, so how much does this skin weight? Okay, कितना वजन होता है स्किन का? The weight will be approximately 4 to 5 kgs. Depending on the person to person, that would vary, but that would be approximately 4 to 5 kg, right? Next thing, we are going to study about the area. So what is the area that is covered by the skin? So area will be 1.72 to 2 meter square. Okay, so तीन चीजें हम लोगों ने देखी. लार्जेस्ट ऑर्गन ऑफ द बॉडी, सेकेंड थिंग विल बी वेट, एंड थर्ड थिंग विल बी एरिया. ओके, नाउ लेट्स टॉक अबाउट द layers of skin. What are the different layers that we are having in the skin, right? So first layer, that would be the outermost layer, that is your epidermis. Okay, so the first one would be epidermis. उसके बाद में क्या होगा? बिलो एपिडर्मिस देयर विल बी डर्मिस, बट बिटवीन epidermis and dermis there will be one more thing, right? That is known as dermo epidermal junction. और बेसमेंट मेम्ब्रेन जोन, बेसमेंट मेम्ब्रेन जोन। और डर्मिस के नीचे क्या आता है, व्हाट विल बी बिलो द डर्मिस, देयर विल बी हाइपोडर्मिस, हाइपोडर्मिस। रिमेंबर गाइस, हाइपोडर्मिस इज आल्सो नोन एज सबक्यूटिस, क्या भी बोल सकते हैं इसको, सबक्यूटिस। सो बेसिकली वी आर हैविंग दीज लेयर्स, ओके, इन द स्किन। अगर आप स्किन देखोगे देर विल बी दीज लेयर्स, आउटर मोस्ट लेयर विल बी एपिडर्मिस, उसके बाद में आएगा आपका डर्मो एपिडर्मल जंक्शन, देन देर विल बी डर्मिस एंड बिलो दैट विल बी हाइपोडर्मिस, ओके। सो दीज आर द लेयर। अभी एक एक करके एक एक लेयर को खोलते हैं, वन बाय वन वी विल ओपन ऑल द लेयर्स, ओके। So the first layer that we are going to open would be your epidermis. Okay, पहली layer जो हम खोलेंगे that would be your epidermis. Okay, so what are the different layers that are coming in the epidermis? Okay, so you can remember with the help of a mnemonic, that is, come, let's grab some burger. Okay, we will grab that burger but after exam, okay. So that is the mnemonic, that is, come, let's grab some burger, right? So come means stratum corneum. Remember guys, the meaning of stratum will be a layer. Stratum का मतलब क्या होता है, that is a layer, okay. So the outermost layer would be stratum corneum, okay. Second would be let's, so that would be stratum lucidum. Second would be stratum lucidum. Third would be stratum granulosum. Stratum granulosum. Wherever you are sitting, just try to speak with me, because the more you will speak, the more you will remember, right? And this is the high time, guys, okay. Next one is your S. So stratum spinosum. Stratum spinosum. And the last one is your burger. Burger is your basal, okay. So that is stratum basal. So we are having 5 layers in the epidermis. 5 लेयर होंगी, कौन सी होंगी, कौन सी होंगी, बोले सर, stratum corneum will be there, stratum lucidum will be there, granulosum will be there, spinosum will be there, and basal will be there, okay. So these are the 5 important layers, okay. Look here, this is the diagram, look here. So what are the things that we are going to see? So सबसे नीचे क्या है, what is the lower most, that is dermis, below that hypodermis will be there, okay. उसके बाद में, that is your burger is your stratum basal, then there will be stratum spinosum, then there will be stratum granulosum, then there will be stratum lucidum, and the uppermost layer, that is stratum corneum. One thing you will see here, these are your columnar cells. Look here guys, these are your columnar cells, columnar cells, okay. These are your columnar cells, but as the cell grow upwards, okay, जैसे जैसे ऊपर जाएगा, what will happen, there will be loss of nucleus. Can you see this? There will be loss of nucleus, okay. So nucleus will be lost here, okay. And this is a non-nucleated layer, non-nucleated layer, okay. So there will be no nucleus in the stratum corneum, okay. Apart from this, what else you can see? You can see, sir, this is a melanocyte. What is the function of melanocyte, we will study, but there are certain cells in the skin, right? So in the epidermis, we are having, first we have seen melanocytes, second we have seen keratinocytes, okay. Second we have seen keratinocytes. We are also having Merkel cells, we are also having Merkel cells, okay. We are also having, guys, Langerhans cells, okay. It is not written here, we are also having Langerhans cell. So basically in skin we are having, in epidermis we are having 5 layers, and we are having 4 important cells, okay. First one is your keratinocyte, other are non-keratinocytes. Non-keratinocytes would be your first one is your Merkel cell, second one is your this one is your melanocyte, and the third one is your Langerhans cells, okay. So these are the cells that we need to study about, okay. Look here guys, this is your Merkel cell, and here it is for the sensory neuron, okay. That would be a type 1 slow adapting receptor we will be studying, okay. So these are the layers of skin, and these are the layers of epidermis. समझ में आ रहा है, okay. Next thing, what are the different kind of cells that we are having in the epidermis, okay. So we are going to see about the different kind of cells that are present in the epidermis. So the first one would be, guys, keratinocytes. I have told you there are 2 types of cells. First one is your keratinocytes, another one is your non-keratinocytes. So keratinocytes would be these are your most abundant cells, most abundant cells. Keratinocytes are your most abundant cells, and they are present in all layers. They are present in all the layers. Okay, keratinocytes are the most abundant cells and they are present in all layers. Sir, what is the function of keratinocytes? Okay, so function of keratinocytes would be, guys, it would be providing us the protection. Okay, it would be providing us the protection. Along with that, what will happen, there is a synthesis of one hormone from the skin, that is one vitamin or hormone, you can also say. Vitamin A and D are considered as hormone as well, right? So this is your vitamin D synthesis, vitamin D synthesis. Okay, so these are the function of keratinocytes. One important question that has been coming up in your exam, that is, where does it come from? Okay, where does keratinocytes come from? So these are ectodermal in origin. Okay, these are ectodermal in origin. कहाँ से आते हैं keratinocytes? They are coming from the ectoderm. Okay, second one is your melanocytes. Okay, second one is your melanocytes. They are approximately 8 to 9%. They are approximately 8 to 9%, and melanocytes will be secreting what? Melanosomes. Remember, guys, melanocytes will be secreting melanosomes. Okay, and that melanosomes will be forming melanin. और मेलेनिन का फंक्शन क्या होता है? व्हाट इज द फंक्शन ऑफ मेलेनिन, गाइस? द फंक्शन ऑफ मेलेनिन इज टू provide color, right? So that would be giving us the color, and we are having two types of melanin. First one is your eumelanin. And the second one is your pheomelanin. So what is the color eumelanin will give you? So the eumelanin will give you brown or black color. Eumelanin will give you brown or black color, whereas pheomelanin will give you white color, white, or you can say yellow color. There is a classification known as Fitzpatrick classification. Fitzpatrick ने क्या किया? He has classified on the basis of color. Okay, in the grades 1 to 6. Okay, so he has classified, right? So this is about the melanin. Okay, melanocyte will be present in stratum. कौन सी लेयर में मिलेंगे? Basal. You know what will happen, guys? Here, look here. So this is stratum basal. What will happen here? We are having melanocytes. Stratum basal के अंदर क्या होगा? हमारे पास में melanocytes होंगे. So these are your melanocytes. इनकी dendritic structure, इनकी structure कैसी है? Dendritic है. Dendritic means they are having these dendrites. Okay, so this is a dendritic cell, and now what will happen? This melanocyte will be secreting melanosomes. Okay, this melanocytes will be secreting melanosomes, and those melanosomes will be providing melanin to adjacent keratinocytes. Okay, now what will happen? Look here, what will happen here? These are your melanosomes. Okay, these are your melanocytes. Means melanocytes will be secreting melanosomes, and that melanosome will be giving color to adjacent keratinocytes. Right? So what will happen? One melanocyte will be giving rise color to how many keratinocytes? One melanocyte, important question, will be giving color to adjacent 36 keratinocyte. How many keratinocyte? 36 keratinocyte. And what do we call it? We call it, guys, epidermal melanin unit. And this is an important question. What is a epidermal melanin unit? So in epidermal melanin unit, what will happen? One melanocyte will be giving rise to 36 keratinocytes. Okay, कितने को color देगा? 36 keratinocytes. Important, one more important question from here, that is your, where does melanocytes came from? Okay, so where does it came from? Where does it derived from? Derived from, so they are derived from which layer, guys? They are derived from neural crest cells. They are derived from neural crest cells. Okay, next one is your important, guys, very very important question. This is a image spotter that has been coming up in recent multiple examinations. Okay, be it NEET PG, be it FMG, multiple times this question has been asked, right? So Langerhans cells, guys, these are basically, these are also dendritic cells. They are present in stratum spinosum. Okay, what is the function of Langerhans cells? They are, write down, they are present only in stratum spinosum. कहाँ पर present होंगे? They are present in stratum spinosum. One thing that is important, guys, they are basically macrophages. Okay, they are macrophages of skin. Okay, we are having macrophages and we give different name to same macrophages. Okay, for example, let's say if the macrophages are present in the liver, what do we call it? Write in the comment section, guys, what do we call it if there are macrophages present in the liver? Okay, if macrophages are present in the liver, we call it, guys, कफर सेल्स. कौन से सेल्स बोलेंगे उनको? कफर सेल्स. ओके, इफ मैक्रोफेजेस आर प्रेजेंट इन द स्किन, वी कॉल इट लाइकवाइज लैंगरहैंस सेल्स. ओके, स्प्लीन में कौन सा होता है? स्प्लीन में देयर विल बी लिटोरल सेल्स. ओके, माइक्रोग्लियल सेल्स इन द ब्रेन. ओके, एंड इन द kidney you are having mesangial cells. Okay, and so this is how we are giving the nomenclature. Okay, so basically they are, what are they, guys? Basically they are macrophages. Okay, all right. Now next, where they are derived from? Okay, because they are macrophages, so they must be derived from bone marrow. Okay, and we can also call it mesodermal in origin. Okay, इनका origin कैसा होगा? Mesodermal in origin. Okay, they are basically antigen presenting cells. They are basically antigen presenting cell. और ये जो structure दिख रही है, that structure, this is known as like, this is known as, कौन सी appearance है? This is known as tennis racket appearance. This is tennis racket appearance, and this is known as Birbeck granule. क्या बोलते हैं इसको? Birbeck granules. What do we call it? We call it Birbeck granules. Okay, Birbeck granules with tennis racket appearance. बच्चों में एक डिजीज होती है, दैट इज Langerhans cell histiocytosis और histiocytosis X. ओके, उसमें हम लोगों को कौन सी अपीयरेंस दिखेगी? दैट इज योर टेनिस रैकेट अपीयरेंस. ओके, नेक्स्ट थिंग, what are the hallmarks? Okay, this is the hallmark. What are the markers that we can use for identification of, what are the markers that we can use here? These are your CD1A, second one is your S100, and most important is your CD207. This one is most important. These are all the markers. Okay, these are important. Two things we need to remember. First, tennis racket appearance and Birbeck granules, they are seen in Langerhans cell histiocytosis. Second important thing would be CD1A, S100 and CD207. CD207 is very important. Okay, next thing, let's talk about next cells. These are your Merkel cells. Merkel cells are slow. These are basically touch receptor. These are basically touch receptor. These are type 1. What are Merkel cells? These are type 1 slow adapting. These are basically type 1 slow adapting touch receptor. क्या है ये? These are basically type 1 slow adapting touch receptor. One question from physio. Okay, one question from physio. These Merkel cells are present in, so we have already seen these are present in epidermis. One more thing is there. where does Meissner's corpuscles are present? Okay, one more thing is there. Meissner's corpuscle कहाँ होते हैं? Okay, till then you answer in the comment section. Till then we are looking where does it come from. Okay, so Merkel cells are coming from which layer? Again, these are ectodermal in origin. Okay, so they are also having ectodermal origin. They are also having ectodermal origin, right? Tell me about Meissner's corpuscle. Meissner's corpuscle. Remember guys, Meissner's corpuscles are present in which layer? Epidermis or dermis? They are present in dermis. Okay, कोई confusion नहीं है. So Merkel cell will be present in epidermis and Meissner's corpuscle will be present in dermis. These are also touch receptor. You will study in physiology. Okay, we'll study together. Next thing, what we have seen the different layers. Okay, so what are the different layers? Stratum corneum will be there, lucidum, granulosum, spinosum, basal, melanocytes, and these are your dermis. Okay, so now we will correlate this thing with the histopatho part. Okay, so look here, कैसा दिखता है? So this is your stratum corneum. यहाँ पर कोई nucleus नहीं है. And this one is your stratum corneum, devoid of nucleus. After stratum corneum, there will be stratum lucidum. Remember guys, lucidum is a clear cell layer. यहाँ पर elidin के granules होते हैं. It is a clear cell layer. Is it visible? Yeah. Okay, next one is your stratum granulosum. Granulosum नाम में ही लिखा है. What will be there? What do you find over there? You will find granules. Okay, वहाँ पर granules होंगे. दो तरीके के granules मिलेंगे. First one is your keratohyaline granules. Second one is your lamellar granules. दो तरीके के granules मिलेंगे. Next one is your stratum spinosum. Spinosum को spinosum क्यों बोला? There must be some spines, right? So I will tell you what are the spines. Okay, and the last one is your stratum basal. We have already discussed there will be melanin synthesis. Okay, this one is your basement membrane, and the last one is your dermal papilla. I will be telling you what is dermal papilla. Okay, so two things we need to remember over here. First thing is your what is a stratum spinosum? Why does stratum spinosum called stratum spinosum? Remember guys, these are two keratinocytes. ये दो cells है, दो keratinocytes है. How they are connected? Look here. They are connected with the help of something, right? What do we call it? दो keratinocytes कैसे जुड़े होते हैं? Answer me guys. Two keratinocytes are bind together with the help of desmosomes. Very good. These are connected with desmosomes. Okay, desmosomes are the protein that would be connecting two keratinocytes. Okay, first thing clear, we are having different kind of desmosomes, so we will be discussing them. Okay, next one, what is dermal papilla? Okay, there is one more thing that is retiridges. वो क्या होता है? Okay, चलो देखते हैं. So the part of epidermis, यहाँ पर epidermis है, नीचे dermis है. Okay, so the part of epidermis which is invaginating into the dermis. Okay, epidermis का जो part dermis के अंदर जा रहा है, that is known as retiridges. The part of epidermis which is going into the dermis is known as retiridges. Okay, and the part of dermis which is going into the, which is invaginating into the epidermis, that is known as dermal papilla. इसको क्या बोलते हैं? Dermal papilla. Okay, so we are having two things. What is retiridges we know, and what are dermal papilla. Clear है, इसमें कोई doubts नहीं है, right? So we have learned till now these things. Okay, अभी तक हम लोगों ने देखा what are the different layers that we are having and how they are differentiated, right? Second thing we have seen, we are having four types of cell. हम लोगों ने चारों तरीके के cells देखे. These are your keratinocytes, melanocytes, Langerhans and Merkel cells. Okay, important stuff completed, right? Now we have seen one more thing. Look here guys, these are your Meissner's corpuscle. These are your Meissner's corpuscle, and they are present in which layer guys? This is your which layer? Dermis, right? And this part of dermis which is going into the epidermis, this is known as dermal papilla, and this is the part of epidermis which is coming into the dermis, this is known as retiridges. कोई doubt नहीं है इसमें, clear है, simple है, right? So this is the basic histology. Histopatho अगर image आ जाएगा तो you can easily identify because it is devoid of nucleus. Nucleus कहाँ पर नहीं होता? We have already seen stratum corneum will be devoid of nucleus, right? So let's see one by one about each layer, what are their peculiarities and what are the important things about them, right? So first layer that we are going to start is stratum corneum. सबसे ऊपर क्या है? First one is your stratum corneum. Okay, look here guys, stratum corneum will be absent in which babies? Low birth weight babies and preterm babies. Okay, and it is devoid of nucleus. There will be no nucleus. Okay, we already know. And the maximum keratin is also present in stratum corneum. Second layer is the stratum lucidum. Lucidum सब जगह present नहीं होगा. They will be present in palm and soles. Lucidum सब जगह present नहीं होता. Lucidum will be present in palm and soles, and that is why palm and soles are thicker than as compared to other part of the skin, right? So this is your palm and sole. You can remember, in palm and sole we are having L, and lucidum also we are having L. So this is a clear cell layer and we are having alidin granules. कौन से granules होंगे यहाँ पर? Alidin granules होंगे. Next one is your stratum granulosum. In stratum granulosum guys, we are having two types of granules. First one is your keratohyaline granules. कौन से granules होंगे? First one is your keratohyaline granules. Keratohyaline granules, they will be helping in the formation of filaggrin. Filaggrin बनाता है. क्या करते हैं? Filaggrin. अब filaggrin क्या होता है समझते हैं, देखते हैं. So we are having pre-filaggrin here. We are having pre-filaggrin or pro-filaggrin that would be converting into the filaggrin. That would be converting into the filaggrin. और filaggrin के नाम में ही लिखा है, उसका मतलब क्या होगा? That would be, look here guys, filamentous aggregating protein. Okay, that would be filamentous aggregating protein. Now what will happen when there is defect in conversion of profilagrin to filaggrin? What will happen? There will be some diseases, right? And what are those diseases? Very famous, that is your first one, atopic dermatitis. Dermatitis क्या मतलब हुआ? Dermatitis मतलब inflammation. So there will be atopic dermatitis. And one more disease that can occur, that is your ichthyosis vulgaris. ये सामने जो दिख रहा है, this is the image of ichthyosis vulgaris. This is the image of ichthyosis vulgaris. Okay, यहाँ पर क्या हुआ? There is filamentous aggregating protein नहीं है. So ये जो epidermis है, that would be separating. Okay, ये दूर दूर होगी. Look here guys, this one will be the ichthyosis vulgaris. In whole dermatology guys, whenever I will talk about the term vulgaris का मतलब क्या होता है? vulgaris का मतलब होता है that is most common. vulgaris का meaning क्या होगा? What would be the meaning of vulgaris? That would be guys most common, right? So we are having two diseases. First one is your ichthyosis vulgaris, second one is your atopic dermatitis. Second granules that we are having in the stratum granulosum, these are your membrane coating granules. Okay, इनका दूसरा नाम क्या है? What else we can call them? We can call them Odland bodies or lamellar bodies. Okay, Odland bodies and lamellar bodies. What is their function? Their function is to produce lipid, right? Their function is to produce, function क्या है इनका? They produce lipid. Okay, and if there is a production of lipid, there will be no itching, right? Now what will happen? Look here, this will cause a disease that is known as winter eczema. Winter eczema, and winter eczema is also known as guys astiotic eczema. तो बेसिकली इसकी वजह से क्या हुआ? लुक हियर, देयर इज अ ड्राइनेस. ओके, इसकी वजह से क्या हुआ? बेसिकली देयर इज नो लिपिड, एंड बिकॉज ऑफ लेक ऑफ लिपिड व्हाट विल हैपन? देयर विल बी फॉर्मेशन ऑफ eczema, right? Clear? No problem till now? So what we have seen till now, keep revising with me. First thing, we have seen stratum corneum, then we have seen stratum lucidum, then we have seen stratum granulosum. Okay, stratum granulosum is important. We are having two granules, keratohyaline. Second one is your lamellar bodies or Odland bodies or membrane coating granules. Okay, what are the diseases that are associated? First one is your ichthyosis vulgaris, second one is your atopic dermatitis. Next, membrane coating granules, we are having astiotic eczema or winter eczema, right? नेक्स्ट लेट्स टॉक अबाउट स्ट्रेटम स्पाइनोसम. स्ट्रेटम स्पाइनोसम इज नॉन एज प्रिकल सेल लेयर. क्यों बोला प्रिकल सेल लेयर? सर यहाँ पर ग्रेन्यूल्स होते हैं, यहाँ पर सॉरी ग्रेन्यूल्स नहीं, यहाँ पर क्या होते हैं ये आपके केरेटिनोसाइट्स होते हैं. दीज केरेटिनोसाइट्स आर बाइंड टुगेदर विद द हेल्प ऑफ डेस्मोसोम. ये हम देख चुके हैं. दीज आर बाइंड विद द हेल्प ऑफ डेस्मोसोम्स, राइट? सो लुक हियर, लेट मी जूम इन. So these keratinocytes, they are bind with the help of desmosomes, और इसकी वजह से इनका अपीयरेंस कैसा आता है? The appearance will be like a prickle cell layer. Okay, the appearance will be like prickle cell layer. Okay sir, what are the different kind of desmosomes? बताई दो चलो. What are the different kind of desmosomes we are having, guys? First one is your desmoglein. First one is your desmoglein. Then we are having desmocolin. Next we are having desmoplakin. Okay, we are also having placoglobin. Okay, these are the name. If you remember, please try to remember these two are important. Desmoglein is very important. Okay, we are also having calcium ATPase for the binding purpose. सो दीज आर द टाइप्स ऑफ डेस्मोसोम्स. ओके, हम लोग देखेंगे अगर ये डेस्मोसोम्स में प्रॉब्लम होगी तो आगे क्या होगा. सो दीज आर प्रेजेंट इन द स्ट्रेटम स्पाइनोसम. यहाँ तक क्लियर है? नेक्स्ट लास्ट वन इज योर स्ट्रेटम बेसल. ओके, स्ट्रेटम बेसल, this is the this is the layer where you will get maximum keratinocytes. This is the layer where you will get the maximum keratinocytes. Okay, here we can also see what are the cells here present. Melanocytes are also present here. Melanocytes. Okay, melanocytes are also present here. Next entity is epidermal turnover time. What is the meaning of epidermal turnover time? Okay, what will happen, guys? This is your stratum basal. This is your stratum corneum. Okay, what will happen? The cell will move upward. Okay, the cells will move upward from the base to the corneum to the top, right? And this will take approximately 52 to 75 days. The average would be 56 days. Okay, so from basal to stratum corneum, from stratum basal to stratum corneum, it will take approximately 28 days. कितने दिन लगते हैं? 28 days. And this is known as epidermal transit time. This is known as epidermal transit time. Then what will happen, guys? Then what will happen? Look here. This will be, this stratum corneum will be shed off in the environment in next 28 days. Okay, so from the basal to corneum it will take 28 days, and from corneum to the environment it will again take 28 days. So that would be approximately 56 days. Okay, so average would be 56 days. But this will be decreased in the cases of psoriasis. It will be approximately 4 days in the cases of psoriasis. We are going to study in detail what are psoriasis and what are different things we need to remember. Okay, so till now we have seen all the cells, we have seen all the layers. We are having all the 5 layers. Come, let's grab some burger. We have discussed. Okay, so these are the 5 layers that we have seen. We have seen a little bit of the anatomy. Okay, so these are the things that you should be remembering. Okay, now let's move on to certain disorders. Okay, first disorder is parakeratosis. What is the meaning of parakeratosis? The meaning of parakeratosis, guys, would be there will be presence of nucleus in stratum, presence of nucleus in stratum corneum. इसका मतलब क्या होगा? There will be presence of nucleus in the stratum corneum. Okay, that is parakeratosis. What are the disorders? कब कहाँ मिलेगा? First thing, you can remember with the help of a mnemonic, that is peace. Okay, P is for you will see it in the cases of psoriasis. कौन सी डिजीज में दिखेगा? Psoriasis. E for eczema. A for actinic keratosis. Actinic keratosis. Just remember it is as it is, actinic keratosis. Next one is your seborrheic dermatitis. Seborrheic dermatitis क्या होता है? What is seborrheic dermatitis? it is basically dandruff, nothing but your dandruff, right? Next one is your S, that is your squamous cell carcinoma. You can say squamous cell carcinoma. So these are the conditions, these are the conditions where we are having parakeratosis. Okay, यहाँ पर हम लोगों को क्या मिलेगा? We will be finding parakeratosis over here. Next one is your dyskeratosis. Dyskeratosis मतलब abnormal keratinization. Okay, dyskeratosis मतलब abnormal keratinization. This keratosis मतलब abnormal keratinization. Okay, so we are having two things. First one is your parakeratosis. Second one is your dyskeratosis. Parakeratosis में there will be retention of nucleus in the stratum corneum. Second thing, in dyskeratosis there will be abnormal keratinization. Okay, in which diseases we will see dyskeratosis? कहाँ कहाँ दिखेगा? The first one is your benign diseases like Hailey-Hailey or Darier's disease. These are basically pemphigus group of disorders. We will study pemphigus, pemphigoid, all those things we will be studying. Okay, second one is your pre-malignant diseases like Bowen's disease, and in malignant conditions like squamous cell carcinoma. Okay, so in these conditions you will be finding dyskeratosis. Okay, dyskeratosis. What is acantholysis? Okay, what is acantholysis? Acantholysis is nothing but the separation of keratinocytes. Okay, जब keratinocytes separate हो जाएंगे, then we call it acantholytic cells. Okay, so this is nothing but your separation of, write down, separation of separation of keratinocytes. So basically these are the separation of keratinocytes. Okay, now what will happen? Acantholytic cells कैसे बनेंगे? Let's look here. So these are your basically these are your two keratinocytes. होगा क्या? These are generally binded together with the help of again desmosomes, right? So suppose here desmoglin is there. Okay, now what will happen? There is a breakage in between these two keratinocytes. Okay, ये दोनों अलग हो गए. What will happen? These two keratinocytes are fell apart. Now what will happen? This will be a single acantholytic cell and this one will be a single acantholytic cells. Okay, how you will visualize these cells, how you will see, you will see them in the Zank smear. क्या बनाना पड़ेगा? You need to make Zank smear. कैसे देखोगे? Zank smear में देखोगे. Look here, these are the separated keratinocytes. Okay, these are the separated keratinocytes. These cells are separated and these are known as acantholytic cells. Okay, in pemphigus vulgaris what will happen? I will be telling you the meaning of pemphigus and all these things in the later part of the class. So just don't worry, just remember for now, just remember in pemphigus vulgaris there will be antibody against, or there will be damage in which type of desmoglin, that is desmoglin 3. Okay, desmoglin 3. In pemphigus foliaceus there will be damage in the desmoglin 1. Okay, वल्गेरिस में क्या होगा? 3 होगा और फोलिशियस में क्या होगा? फर्स्ट होगा. दैट वुड बी फर्स्ट फॉर एफ फॉर फर्स्ट, दैट इज योर डेस्मोग्लिन 1. ओके, पैरानियोप्लास्टिक में क्या होगा? देयर विल बी डैमेज इन द डेस्मोप्लेकिन और प्लेकोग्लोबिन. यू कैन रिमेंबर पी याद कर लो. ठीक है, सो दैट वुड बी डेस्मोग्लिन और that would be desmoplakin or plecoglobin. Next one is your Darier's or Hailey-Hailey disease. These are due to defect in calcium ATPase. These are due to defect in calcium ATPase. Okay, so these are the acantholytic cells. We have seen dyskeratosis, we have seen parakeratosis, and we have seen acantholytic cells. Okay, हम लोगों ने देखा pemphigus vulgaris में there will be defect in which antibody, that is your antibodies are formed against desmoglin 3. Okay, in pemphigus foliaceus antibodies are formed against desmoglin 1. In paraneoplastic pemphigus antibodies are formed against desmoplakin and plecoglobin. Okay, and the last one is your Darier's, that is your calcium ATPase के against antibody बनेगी, be it your IgG type or IgA type. आगे देखेंगे उनको. ठीक है, so this is your Zank smear. नाउ लेट्स टॉक अबाउट द माइक्रो एब्सेस. मतलब क्या होता है माइक्रो एब्सेस? माइक्रो मतलब छोटा, एब्सेस मतलब एब्सेस. नाउ एब्सेस इज एब्सेस कैन बी ऑफ टू टाइप, इट कैन बी लिम्फोसिटिक, इट कैन बी न्यूट्रोफिलिक. मतलब क्या हुआ एब्सेस का, देयर विल बी एक्यूमुलेशन ऑफ WBCs, देयर विल बी एक्यूमुलेशन ऑफ WBCs. Okay sir, what are the different kind of WBCs we are having? Two types, two types we need to remember, that is your neutrophilic and lymphocytic. Okay, neutrophilic will be more in like bacterial infections, and lymphocytic will be more in like viral infections. Okay, so we can see these type of abscesses. Okay, so the first one is papillary tip microabscess. Where do you find papillary tip microabscess? कौन सी डिजीज में दिखेगा? आंसर में गाइस, कौन सी डिजीज में दिखेगा? इन विच डिजीज यू विल फाइंड पेपिलरी टिप माइक्रो एब्सेस? In which disease you will find papillary tip microabscess? Papillary tip microabscess किस कौन सी डिजीज में दिखेगा? Papillary tip microabscess will be seen in dermatitis, dermatitis herpetiformis, dermatitis herpetiformis. क्या मतलब हुआ पेपिलरी टिप माइक्रोएप्सिस? अभी हम लोगों ने पढ़ा था थोड़ी देर पहले, we have studied about the dermal papilla and rete right? We have seen dermal papilla and rete rete. Okay, so what will happen guys here? So this one is the rete because the part of epidermis which is going into the dermis, that is known as rete right? And the part of dermis that is going into the epidermis, that is known as dermal papilla. Okay sir, I got this. Now what will happen? There will be accumulation of WBCs, right? There will be accumulation of WBCs in this dermal papilla part, and that is known as papillary tip microabscess. Clear है? कोई doubt नहीं है? Next thing. Next is your Munro's microabscess. Okay, Munro microabscess will be seen in a disease that is psoriasis. This is direct questions guys. This has been asked in multiple times. बहुत बार पूछा गया है. You should be remembering these things. Okay, Potterier's microabscess will be seen in mycosis fungoides. Mycosis fungoides. It is not a fungal infection. नाम से लग रहा है it is a fungal infection, but it is not a fungal infection. It is a cutaneous T cell lymphoma. It is a cancer. Okay, epidermotropism होता है. It is a cancer. It will be coming towards the epidermis. Okay, so that is Potterier's microabscess. Okay, Kogos pustules. I will be showing you the images and I will be telling you कैसे होगा. So Kogos pustules will also be found in psoriasis. कहाँ दिखेंगे Kogos pustules? Psoriasis. Okay, so these are the important points. Revise with me. First thing, papillary tip microabscess will be seen in dermatitis herpetiformis. Munro's microabscess will be seen in psoriasis. Just remember M for P and P for M. Don't mix Munro microabscess with mycosis fungoides. Don't do this. Okay, just remember M के साथ में हमेशा P आएगा और P के साथ में M आएगा, मतलब MP याद कर लो. ठीक है, so Potterier will be in the mycosis fungoides, Munro microabscess will be in the psoriasis, right? Next one is your Kogos pustule. Okay, Kogos pustule will be seen in psoriasis. I will be showing you the images. Okay, so till now what we have seen, remember guys, what we have seen, we have opened the skin from the outside. सबसे बाहर की layer, first सबसे बाहर की layer, that is epidermis. Then there will be basement membrane zone, then there will be dermis, and then there will be hypodermis. यहाँ तक clear है, कोई दिक्कत नहीं है. ठीक है सर, तो हम लोगों ने क्या किया? We have opened the epidermis. In epidermis we are having 5 layers. Come, let's grab some burger. Okay, so we have studied about all the important points in these 5 layers. Okay, then we have studied about the 4 different types of cells. These are keratinocytes and non-keratinocytes. उसके बाद में हम लोगों ने पढ़े disorders. Then we have seen about the disorders like parakeratosis, dyskeratosis and acantholysis. And then we have studied about the microabscesses. Okay, so with this we are almost done with the epidermis, right? यहाँ तक clear है, कोई doubts नहीं है. Okay, next thing, let's talk about basement membrane zone. अभी मैंने बताया दो एक्एंथोसाइट्स, दो केरेटिनोसाइट्स कैसे बाइंड करेंगे आपस में? विद द हेल्प ऑफ डेस्मोसोम्स. ओके, they are bind together with the help of desmosomes. Two keratinocytes are bind together with the help of desmosomes, right? Now we will be studying how they are connected with the basement membrane. Suppose this is a keratinocyte, and how this will be connected with the basement membrane. ये नीचे कैसे जुड़ा होगा, ठीक है? So this these two keratinocytes, suppose this is keratinocyte 1, this is 2, they are bind together with the help of desmosomes. Okay, no problem, we are having desmoglein, desmocholine, all those things we have seen, right? Now these keratinocytes will be bind with the help of something to the basement membrane, right? So what are the things that would be helping these keratinocytes to bind with the basement membrane? These are known as which protein, guys? These are known as which protein? Answer me in the comment section, guys. These are known as, these are known as, let me see if you are answering. These are known as, these are known as hemidesmosomes. These are known as hemidesmosomes. इनको क्या बोलेंगे? Hemidesmosomes. Okay, hemidesmosomes. These are known as hemidesmosomes. So basically, two keratinocytes are bind together with the help of desmosomes, and one keratinocyte is binding with the basement membrane with the help of hemidesmosomes. कौन से प्रोटीन होते हैं? हेमीडेस्मोसोम्स. ओके, याद रहेगा. नेक्स्ट थिंग, अब देखो हेमीडेस्मोसोम्स में क्या क्या होगा, कैसे कनेक्ट होगा. वी आर हैविंग सर्टेन प्रोटीन्स, we are having certain hemidesmosomal protein. Okay, these are your plectin, these are your integrin, bpag1, bpag2. Okay, so remember important, याद कर लो, bpag1, bpag, इसका मतलब क्या, व्हाट इज द मीनिंग? यू कैन रिमेंबर लाइक बुल्लस पैम्फिगोइड एंटीजीन 1. ओके, सो bpag1 और bpag2, अगर इनका म्यूटेशन होता है, इफ देर इज म्यूटेशन ऑफ bpag1 or bpag2, then what will happen, guys? There will be a disease known as bullous pemphigoid. Simple, right? Pemphigoid. There will be a disease known as bullous pemphigoid. बुल्लस पैम्फिगोइड हो जाएगा, राइट? अगर डेस्मोसोम्स में डिफेक्ट है, देर विल बी ए डिजीज नॉन एज पैम्फिगस. अगर डेस्मोसोम्स में गड़बड़ है, यहाँ पर अगर दिक्कत है डेस्मोसोम्स में, देन वी आर हैविंग ए डिजीज दैट इज नॉन एज पैम्फिगस. ओके, उसको क्या बोलेंगे? पैम्फिगस बोलेंगे. एंड इफ देर इज डिफेक्ट इन द bullous pemphigoid antigen 1 or 2, then we are having a disease that is known as bullous pemphigoid. ये कहानी समझ में आई? अब देखो क्या होता है, लुक हियर, these are two keratinocytes. Okay, अगर इन दोनों के बीच में if there is a defect in desmosome, then what will happen? आपके they are present in epidermis, they are present in epidermis, right? epidermis में desmosomes है, desmosomes. now what will happen? अगर अगर यहाँ पर डिफेक्ट है, if the defect is in the desmoglein, then what will happen? the epidermis will लूज अपार्ट. ओके, ये क्या होगा? ये दोनों सेल्स अलग अलग चले जाएंगे. दिस विल बिकम अकेंथोसाइट्स. ओके, एंड दिस विल फॉर्म अ ब्लिस्टर. ब्लिस्टर हो जाएगा यहाँ पर, एंड दिस इज नोन एज पैम्फिगस. इसको क्या बोलते हैं? पैम्फिगस बोलते हैं, ठीक है? एंड इन बुल्लस पैम्फिगोइड व्हाट विल हैपन? यहाँ पर केरेटिनोसाइट्स आर ओके, डेस्मोसोम्स आर ओके. Okay, these are okay, but there is a problem with the basement membrane zone. I have told you इनको कौन जोड़ता है? What is the structure that is binding them? This is your hemidesmosome. So what will happen, guys? Here what will happen? Look here, what will happen? There will be problem in the basement zone connection. Okay, so there will be deep bulla. बुल्ला होगा, बुल्ला मतलब होता है देर विल बी ब्लिस्टर. ओके, सो देर विल बी डीप बुल्ला, और दिस डिजीज इज नोन एज बुल्लस पैम्फिगोइड. ओके, दोनों में डिफरेंस समझ में आया? द फर्स्ट वन इज पैम्फिगस. पैम्फिगस में देर विल बी डिफेक्ट इन द डेस्मोसोम्स. ओके, सेकेंड वन इज योर बुल्लस पैम्फिगोइड, देर विल बी डिफेक्ट इन द BPAG gene. Okay, next one, so this is your basement membrane zone. Okay, these are the things: plectin, integrin, BPAG1 और BPAG2. BPAG1 is also known as BP230. कई बार एग्जाम में BP230 दे देते हैं. and this one is known as BP180. Okay, this one is known as BP180. Most common cause for bullous pemphigoid would be BPAG2 more than BPAG1, right? Now let's talk about the dermis, the lowermost layer, that is dermis. In dermis, what you need to remember, guys, we are having two layers in the dermis as well. First one is your papillary dermis, and second one is your reticular dermis. दूसरा कौन सा है? Second one is your reticular dermis. So we are having two layer in the dermis itself. That is, first one is your papillary dermis, second one is your reticular dermis, right? So look here in papillary, what is the collagen that is most abundant over here? Write down the collagen which is most abundant over here is collagen 1 as compared to collagen 3. What other things will be present here? There will be presence of fibroblasts. There will be presence of hyaluronic hyaluronic acid. Okay, यहाँ पर क्या होगा? There you will see multiple things. You will see fibroblast, elastic fiber, collagen fibers, blood vessels, okay, macrophages. All those things will be present in the dermis part. Okay, these are the two layers of the dermis. Okay, epidermis we have seen, basement membrane zone we have seen. Okay, this one is basement membrane zone. Now we have seen the dermis. Dermis is also divided into two parts. First one uppermost is papillary dermis, and then there will be reticular dermis. Okay, and the last one would be hypodermis. Okay, hypodermis is also known as subcutaneous layer, also known as subcutaneous, also known as paniculus. This is also known as paniculus. And what is the inflammation of subcutaneous layer? That is paniculitis. This is important. This has been asked in your examination. What is paniculitis? So paniculitis is nothing but your inflammation of subcutaneous layer or subcutaneous layer. Okay, so these are the layers of the skin. These are the basics of dermatology. Okay, now we will talk about certain type of skin lesions. Okay, अब हम लोग पढ़ेंगे skin lesions के बारे में. So we are having two types of skin lesions. First one is your primary skin lesion and second one is your secondary skin lesion. क्या difference होता है primary और secondary में? Look here guys, primary skin lesions are those lesions which are due to primary disease. Okay, primary lesions are due to disease itself. Disease itself. Okay, secondary lesions are those lesions which are basically primary lesions but they are not adequately treated, or they can be due to trauma. Okay, so secondary lesions क्या होंगे? These are basically they are primary lesions which are, these are basically primary lesions which are not adequately treated, which are not adequately treated. Okay, ठीक से treatment नहीं हुआ, that would be converting into secondary lesion. So okay, and this can be due to trauma as well. Trauma की वजह से भी हो सकते हैं. So what are the different primary lesions? So there will be macule, papule, nodule. I will be telling. Okay, tumor, plaque, wheal, vesicle. Okay, bulla, pustule. So these are confusing terms. I will be telling you now. And secondary lesions will be your scales, crust, fissure, ulcer, scar, atrophy. Okay, so you should be knowing what are the primary lesions and what are the secondary lesions. Basic difference I have told you. Primary lesions are due to primary disease, due to disease itself, and secondary lesions are those lesions, those are not treated. Okay, those are not adequately treated, or they can be due to trauma as well. Okay, look here guys. So let's talk one by one about the primary lesions, primary skin lesions, and then we will study about the secondary skin lesions. Okay, so first one, this is your fluid filled lesion. Fluid filled. If you are seeing clear fluid filled lesion, if you are looking at clear fluid filled lesion, that is your bulla. Okay, bulla will be more than 1 centimeter. Bulla मतलब क्या होगा? There will be fluid filled lesion more than 1 centimeter. If it is less than 1 centimeter, we call it vesicle. Okay, ये दोनों क्या है? Both of them are clear fluid filled lesions. Okay, so if it is less than 1 centimeter, this is also a fluid filled lesion. Okay, let's talk about the flat lesions. Okay, flat lesions की बात करूँ, so if it is less than 1 centimeter flat lesion, we call it macule. Okay, this is circular flat discoloration, we call it macule. इसको क्या बोलेंगे? macule बोलेंगे. अगर ये 1 सेंटीमीटर से बड़ा है, circumscribed flat lesion more than 1 centimeter, तो इसी को हम लोग क्या बोल देते हैं? What do we call it? We call it patch. Okay, so we have seen two things. First, fluid filled lesion less than 1 centimeter would be vesicle, more than 1 centimeter would be bulla. Okay, second thing we have seen flat lesions. Okay, flat lesions less than 1 centimeter would be macule, and more than 1 centimeter agar flat lesion hai, that would be your patch. Okay, that would be your patch. Let's talk about superficial solid lesions. Superficial solid lesions. Okay, this is your papule. Papule is a superficial solid lesion less than 0.5 centimeter. Okay, if it is less than 0.5 centimeter, we call it papule. Okay, if it is more than 1 centimeter, we call it plug. ठीक है, अगर ये 1 centimeter से बड़ा होगा, then we will call it plug. Okay, after that, if it is circular, elevated and deep lesion, we call it nodule. It is also more than 1 centimeter. It is also more than 1 centimeter. And such lesions, if they are having pus in between, okay, अगर इनके अंदर pus होगा, if the vesicle is having pus, then we call it pustule. Okay, then we call it pustule. Okay, and if the pus filled lesions are more than 1 centimeter or they are big, we call it big lesions, we call it abscess. क्या बोलेंगे उसको? Abscess. Okay, we call it abscess. Okay, this one is your wheal. Wheal is a characteristic feature in which disease? कौन सी disease में दिखता है? Look here guys, this will be seen in urticaria. Okay, this is basically edematous lesion that will be seen in urticaria. Scales are basically epidermal thickening. We have seen epidermis, so scales will be epidermal thickening. We will study about scales in further details. Okay, next one is your crust. Crust is basically dried up exudate. Crust क्या होता है? Crust is nothing but dried up exudate. Okay, अगर single linear split है, then we call it fissure. This is your fissure. Okay, this is your fissure. Excoriation, linear erosion अगर है तो we call it excoriation. Erosion मतलब there will be erosion and there will be ulcer. So erosion will be loss of epidermis. Erosion किसको बोलेंगे? We call it erosion, that is loss of epidermis. But if along with the epidermis, dermis is also damaged, then we call it ulcer. Okay, ulcer क्या होता है? Loss of epidermis plus dermis. बिफोर दैट अगर सिर्फ एपिडर्मिस में डैमेज है, देन वी कॉल इट इरोजन. ओके, और लीनियर इरोजन को हम लोग बोलते हैं एक्सकोरिएशन. वी कॉल लीनियर इरोजन एक्सकोरिएशन. ओके, इरोजन विल बी लॉस ऑफ एपिडर्मिस. Lichenification will be seen in, we will be studying about the lichen planus, so that would be thickening of epidermis. Okay, thickening of epidermis. And this one is your scar. Scar is also a scar is a fibrotic change, and that is permanent. Once a scar, always a scar. Okay, so these are the basic lesions. These are your primary and secondary lesions. Okay, so this is, you should be remembering. Okay, we have done with the basics part. Okay, now we will be studying about the skin appendages. Skin के अंदर कौन से appendages होगी? So we will be having hairs, we will be having nails, we will be having glands, right? स्किन के साथ में क्या क्या होता है? वी आर हैविंग हेयर्स, वी आर हैविंग नेल्स, एंड वी आर हैविंग सर्टेन ग्लैंड्स. व्हाट टाइप ऑफ ग्लैंड्स वी आर हैविंग? लुक हियर गाइस, वी आर हैविंग टू टाइप्स ऑफ ग्लैंड. वी आर हैविंग आइदर स्वेट ग्लैंड होती है. सेकेंड, वी आर हैविंग सिबेशियस ग्लैंड्स. कौन सी ग्लैंड्स होती है? सिबेशियस ग्लैंड्स. वी आर हैविंग टू टाइप्स ऑफ ग्लैंड्स. फर्स्ट वन इज योर स्वेट ग्लैंड, सेकेंड वन इज योर सिबेशियस ग्लैंड्स, राइट? So let's see one by one. First, let's start with the nails. Okay, what are the different type of nail changes that we need to look for? Okay, तो nail changes की बात करेंगे. First image that you are looking here, that is the image of clubbing. You can easily identify clubbing. Okay, clubbing is due to hypoxic. This is due to hypoxic condition. Okay, like clubbing is seen in those patients which are who are suffering from chronic hypoxic diseases, like your COPD, like your emphysema. In these patients, this one is the common finding. Okay, that is your clubbing. Okay, second one is your spoon shaped nail. Okay, कोइलोनिकिया मतलब क्या है? spoon shaped nail. Okay, कोइलोनिकिया is spoon shaped nail. Okay, this one is seen in Plummer-Vinson syndrome. Can anyone tell me what is the triad for Plummer-Vinson syndrome? Okay, along with that, iron deficiency anemia. Next one is your Aldrich-Mees line. Mees line will be seen in, these are basically horizontal lines. Look here, these are basically horizontal lines. These are seen in which poisoning, guys? These are seen in arsenic poisoning. Okay, this one is the pterygium. This one is your proximal nail fold will be dividing the nail into two part. Okay, this proximal nail fold is dividing the nail into two part. This is known as pterygium. It is the characteristic, it is the most characteristic finding of which disease? Lichen planus. Finding of lichen planus. Okay, pterygium is the most characteristic finding of lichen planus. Okay, प्लमर विंसन syndrome में क्या होगा? Esophageal esophageal webs will be there. Iron deficiency anemia will be there. Okay, this one is your iron deficiency anemia. There will be esophageal webs will be there. There will be koilonychia. These are the things we will see in Plummer-Vinson syndrome. Okay, this is your pterygium. Okay, this one is your oil drop sign. Oil drop sign. Oil drop sign is the most characteristic finding. This is the most characteristic finding of psoriasis. These are all questions, guys. These are all questions. Most characteristic finding of psoriasis. The answer would be oil drop sign. Okay, if they ask you what is the most common finding of psoriasis, then the answer would be thimble nails. Okay, thimble nails. These are basically pitted nails. Okay, so this is the most common finding. Most common finding would be thimble nails in psoriasis, and most characteristic finding would be oil drop sign. Okay, these are your Buse line. Buse line, look here, guys. These are depressed. These are basically depressed and growing lines. These are basically depressed and growing lines. Okay, this one is your Muir case line. These are basically, these are, look here, these are non depressed. These are non depressed and non growing. Muir's line is non depressed and non growing, and they both of them are seen in chronic illnesses. Both of them are seen in chronic illnesses. Both of them are seen in chronic illnesses. Okay, this one is your onychogryphosis. Onychogryphosis, or you can say distorted nail. Okay, distorted nail or ram's horn nail. Okay, ram's horn nail. This is due to trauma. This is due to trauma. Okay, next one is your half nail sign. Half nail sign, or you can say Lindsay's nail. यहाँ पर क्या होगा? Look here. Half nail is red, half nail is erythematous, and half is white. Okay, so there will be erythematous. Half nail is erythematous and half is pale. This one would be seen in the cases of chronic renal failure. कौन से patients में दिखेगा? You will see these cases in the patients of chronic renal failure. These are also looking like same, but remember, guys, here we will see ground glass opacities. Look here, ground glass opacity. How we will differentiate? We will differentiate with the ground glass opacities that would be found in the teres nail, and that would be seen in the cases of pemphigus as well as in the cases of hepatic failure. Write down hepatic failure. So this is what you need to remember about nails. Okay, these are the important findings of the nail that you should be remembering. Right, now let's talk about the hair follicle. Okay, hair follicle, we are having three things, guys. We are having three things. We are having anagen phase, catagen phase, and telogen phase. Okay, तीन phase होगी, anagen, catagen, and telogen. Anagen is the, write down, anagen is the growing phase. Anagen is the growing phase. Catagen is the transient phase. Catagen कैसी phase होती है? It is a transient phase. Transient phase. And telogen is the resting phase. Telogen is the resting phase. So we are basically having three phases, A, C, T. Anagen will be lasting for years, that is approximately 2 to 6 years. Catagen will be lasting for weeks only, and telogen will be lasting for months, that would be approximately 3 months. Okay, so these are the three phases of hair cycle. Okay, these are the three phases of hair cycle. What do we call the study of hairs? What do we call the study of hairs? Study of hairs को क्या बोलते हैं? And what do we call the loss of hairs? Answer me, guys. So the study of hairs is known as trichology, and the loss of hair is known as alopecia. Loss of hairs is known as alopecia. So we are having different type of alopecia. ठीक है, कौन से होते हैं? In the males, in male we are seeing the male pattern baldness, or the first thing that we are seeing, that is known as Hamilton pattern. लड़कों के बाल कहाँ से जाते हैं? हैमिल्टन पैटर्न. कहाँ से उड़ते हैं लड़कों के बाल? So that there would be frontal line receding, and there will be loss from the vertex portion. Okay, so that is known as Hamilton pattern. Okay, in females we are having two pattern. Either they lose hair from the vertex portion, or they can lose hair from the part from where they part their hairs. Okay, या तो यहाँ से जाएंगे या यहाँ से जाएंगे. Okay, so we are having two pattern, that is, one is Ludwig, another one is Olsen pattern. Olsen. So we are having two pattern. Okay, in female. नेक्स्ट थिंग इज योर एलोपेशिया एरियाटा. एलोपेशिया एरियाटा मतलब एक एरिया में से क्या हुआ, आपको पैची हेयर लॉस हो गया. ओके, दैट इज एलोपेशिया एरियाटा. ओके, इंपॉर्टेंट थिंग अबाउट एलोपेशिया एरियाटा, राइट डाउन एलोपेशिया एरियाटा. Two important findings we will see here. Okay, the first one, when the here you will find the easily pluckable hair. First thing you will find the easily pluckable hair, because this is a autoimmune condition. This is a autoimmune condition, alopecia areata. So here you will find easily pluckable hair, first thing. Second thing, you will find exclamation mark sign. Okay, you will find exclamation mark sign at the base. Okay, and when you try to look over there, what you will find, around the follicle you will find infiltrates. Okay, WBC infiltrate, that is known as, and this appearance is known as swarm of bee appearance. This appearance is known as swarm of bee appearance. इस appearance को क्या बोलेंगे? Swarm of bee appearance. Two important things. Alopecia areata is a autoimmune disorder. Okay, you can also see turning of gray phenomena. Okay, second thing, exclamation mark sign will be seen here. Third thing, swarm of bee appearance will be seen here. Okay, so these are the important findings about alopecia areata. Okay, apart from this, let's see telogen effluvium. Telogen effluvium, I have told you, this is the resting phase. Okay, resting phase hoga. So what will happen? Let's say if there is a female, she had like certain disease few months back, and now she's losing her hairs. Okay, so basically she is losing hair from that resting phase, right? Suppose someone is having COVID 3 months, 2 or 3 months back, there is a female, and now she is losing their hairs. Okay, so this is a case of telogen effluvium. Okay, क्या करना है? They will be she will regain their hairs again. Okay, so this is your telogen effluvium. Okay, next one is your scarring alopecia. This one is scarring alopecia. You can see scarring alopecia, also known as cicatricial alopecia. इसका दूसरा नाम क्या होता है? What do we call it? Cicatricial alopecia. What else we can call it? We can call it cicatricial alopecia. Okay, you will find these things in like, this can be due to trauma, this can be due to trauma, this can be due to burn, this can be due to radiation exposure. In certain diseases like tertiary syphilis. Okay, you can also see in DLE, that is discoid lupus erythematosus. Okay, so in those cases you will be finding scarring type of alopecia. Okay, scarring type of alopecia. In SLE, remember guys, in SLE we are having both scarring and non-scarring type of alopecia. Okay, this one is a trichotillomania. Trichotillomania is a psychiatric condition, guys. It is a psychiatric condition. Trichotillomania में क्या होता है? It is a psychiatric condition when patient try to pull out her own hair. Okay, वो खुद के बाल खुद ही खींचते हैं. Okay, so that is a psychiatric condition. Next thing is your traction alopecia. This is not very important, but because this one will be because due to regular pulling of hair. This is due to regular pulling of hairs. Traction alopecia. Okay, this one is your anagen effluvium. Anagen effluvium is the first phase. Okay, anagen is the growing phase. So what will happen? Here will be damage due to which drugs? Here will be damage due to chemotherapy drugs, right? chemotherapy drugs. Chemotherapy drugs will be acting on which structures? Okay, chemotherapy drugs will be acting on those structures or those cells which are rapidly dividing. Okay, so we are having bone marrow and we are having hairs, right? So in our hair, what will happen? This chemotherapy drug will be damaging the anagen phase, and I have told you anagen is the growing phase. तो क्या होगा? There will be loss of hairs. Okay, and that is known as anagen effluvium. तो डिफरेंस समझ में आया? एनाजन इफ्लुएम और टिलोजन एफ्लुएम में टिलोजन विल बी 3-4 महीने पहले कोई डिजीज हुई है, एनाजन विल बी ड्यू टू कीमोथेरेपी एजेंट्स. ओके, नाउ लेट्स टॉक अबाउट द ग्लैंड्स. ओके, तो हम लोगों ने क्या क्या देखा? वी आर लुकिंग फॉर द इंटीग्यूमेंट्री सिस्टम बोलते हैं इसको. वी आर लुकिंग फॉर द hairs, nails and glands. Okay, so we have seen the nails pathology, now we have seen the hair pathology. Okay, now we are moving to glands. Okay, तीसरा system पढ़ रहे हैं, that is your glands. So we are having two types of glands. First one is your sweat gland, second one is your sebaceous gland. Okay, तो sweat gland के बारे में देखते हैं. First thing, sweat glands are basically of two type. First one is your eccrine gland. First one is your eccrine gland and second one is your apocrine gland. दो तरीके की होती है. एपो का मतलब क्या होता है? एपो मतलब होता है हमेशा किसी के साथ में. ओके, एपो मीन्स अलोंग. Okay, apo means along or together, so that would be opening along with hair follicle. That would be opening along with the hair follicle. Okay, this one would be eccrine. Eccrine would be E for everywhere. Okay, so eccrine would be present everywhere. First tell me, sweat glands are present maximum in which part of the body? Okay, सबसे ज़्यादा sweat glands कहाँ पर होती है? Right, so tell me, till then we are studying. Okay, so this is your C for cholinergic control. Cholinergic control, so these are under the cholinergic control. Cholinergic control मतलब that would be parasympathetic control. Okay, cholinergic मतलब acetylcholine, acetylcholine मतलब parasympathetic, right? So these are under the parasympathetic control. Okay, apocrine glands are under the which control? A for apocrine, they are under the adrenergic control. They are under the adrenergic control. Adrenergic control मतलब adrenergic मतलब adrenaline, noradrenaline. Okay, so that would be your sympathetic nervous system. Okay, so we are having two types of sweat glands. First is eccrine, second one is your apocrine. Eccrine will be under the cholinergic control and apocrine will be under the adrenergic control. ऐसे ही याद कर लो, A for along with the hair follicle, A for adrenergic control, E for everywhere and C for cholinergic control, or you can say parasympathetic control. दो होते हैं ना अपने पास में, पैरासिम्पैथेटिक और सिंपैथेटिक, राइट? So parasympathetic control. Now what will happen? There will be some diseases. Okay, there will be some disorders. So what will happen when there will be inflammation of eccrine gland? Inflammation of eccrine sweat glands is known as malaria. Malaria. Okay, malaria मतलब prickly heat. Prickly heat मतलब क्या होता है? सबको हुआ होगा. Okay, सबको हुआ होगा. That is your ghamuria, nothing but your ghamuria, right? So this is your prickly heat or malaria. और prickly heat और malaria. रुब्रा मतलब रेड कलर. ओके, सो दैट इज योर prickly heat. We can also have hyperhidrosis. ज़्यादा पसीना आता है, राइट? सो these things can happen. Okay, so we are having maximum sweat glands in which part we are having maximum sweat glands? Let me see if you have answered. So maximum sweat glands will be present in palm, maximum sweat glands will be present in soles as compared to palm. Okay, soles में ज़्यादा होती है as compared to palm. Okay, now let's talk about एपोक्राइन ग्लैंड. एपोक्राइन ग्लैंड का डिसऑर्डर क्या होगा? देयर विल बी फोक्सफोर्डाइसिस डिजीज. ओके, अगर यहाँ पर कुछ होगा दैट विल लीड टू फोक्सफोर्डाइसिस डिजीज. ओके, इफ देयर इज इन्फ्लामेशन ऑफ apocrine gland, we can see foxfordiasis disease. Okay, this is very important, multiple time asked in the exam. Okay, multiple times in the NEET PG in the recent examination, foxfordiasis and this one is your Fordyce's spots. Okay, you should not confuse Fordyce's spots with Fordyce's disease. Okay, they are basically sebaceous glands. Okay, sebaceous glands क्या करेंगी? They will be producing sebum, right? They will be producing sebum. Okay, and they are, look here, this is a sebaceous gland. They are opening with hair follicle. ये कैसे open होती है? Along with the, they are open with the, along with the hair follicle. So they are opening along with the hair follicle. So what will happen if there is blockage, or if there is inflammation of pilosebaceous unit? Pilosebaceous unit का मतलब होता है, pilosebaceous unit is nothing but this one is your sebaceous gland opening along with the hair follicle. If there is inflammation of pilosebaceous unit, इन दोनों को हम लोग क्या बोलते हैं? pilosebaceous unit बोलते हैं. And if there is inflammation of pilosebaceous unit, if there is inflammation of pilosebaceous unit, that will lead to formation of acne. acne हो जाते हैं ना. So acne are due to inflammation of pilosebaceous unit, right? Next thing, this is your Fordyce's spores. Fordyce's spores are nothing but the ectopic sweat glands. Okay, ectopic sebaceous glands. Okay, so these are basically ectopic sebaceous glands. Ectopic sebaceous glands को हम लोग क्या बोलते हैं? We call it Fordyce's spores. Okay, no confusion between Fordyce's spores and Fordyce's Fox Fordyce's disease. Okay, these are Fox Fordyce's disease are sweat glands, and they are sebaceous glands. Very important. This is very confusing. You will forget this, right? So just remember. Next thing, I have told you what is acne. Acne is nothing but the inflammation of pilosebaceous unit. Okay, pilosebaceous unit का inflammation हो जाएगा. That is what is known as acne. What is the most common organism from your microbiology? What is the most common organism that is causing acne? कौन सा organism है guys? Tell me in the comment. Okay, comment section. So that is your, what is the most common organism? Till then we will be looking at the most characteristic lesions. Okay, what are the most characteristic lesions? Most characteristic lesions here. We are having two things. We are having comedones. Okay, in comedones we are having, comedones are the most characteristic lesions, and in comedones we are having two things. We are having two types of comedones. One is blackhead, you can say open comedones, and closed comedones. Okay, comedones are the basic lesions. Okay, we are having two types, open and closed. तो जो open होगा that will react with the environment. Okay, जो open होगा that will react with the environment and it will turn into black color. Okay, so open would be black and closed would be white. तो देखा होगा, you guys must have seen the black heads and white heads. So black heads are basically open comedones. Black heads जो हो जाते हैं that are basically open comedones. Okay, and white heads are basically closed comedones. Okay, so this is the most characteristic lesion. Now we are having, these are mild to moderate and moderate to less severe, and the most severe, that is nodulocystic type of acne. Nodulo, here you will see nodules and there will be formation of cyst, so that is why we are calling it nodulocystic acne. Okay, nodulocystic acne. So look here guys, how we are going to treat the acne. What is the most common organism that is causing acne? That would be your propionibacterium acne. Okay, so that would be your propionibacterium P acne. Okay, so that would be the most common organism that would be causing acne. अभी treatment करोगे तो how you will treat the acne? First thing, what are the drugs that you will give? First would be your retinoids. Retinoids are basically vitamin A derivative. Vitamin A के derivative है. Okay, so we can use retinoids like adapalene. We can use tretinoin. Okay, in the mild to moderate category we can use adapalene, we can use tretinoin. Okay, in moderate categories what we need to do guys, we need to give topical retinoids. along with the topical antibiotics. रेटिनोइड्स तो देंगे ही, साथ में हम लोगों को क्या ऐड करना पड़ेगा, टॉपिकल एंटीबायोटिक्स. सुना होगा, you must have heard about, like, we are giving clindamycin. Okay, so basically we are using antibiotics along with the topical retinoids. In moderate to less severe, what we will do, we will give the topical retinoids. Along with that, we are giving topical antibiotics. We can also use systemic antibiotics, and we can also use benzyl peroxide. Okay. In nodulocystic acne, the drug of choice will be isotretinoin. Isotretinoin. This is important. This is a teratogenic drug. Okay. So if you are giving this drug to the females, you should counsel the female before giving this drug. Before starting this drug, you should counsel the female whether she is about to get pregnant or she is planning a baby. Okay. So these are the acne. Okay, now let's talk about the new topic, that is your papillosquamous disorders. Okay, we have seen the skin appendages. In skin appendages, we have seen these things like nails, hairs, and your sebaceous and sweat glands. Okay, so we have seen all the things, all the important questions that has been asked from these topics. Okay, so these are the important things. Okay, now let's talk about the papillosquamous disorder. In papillosquamous disorder, guys, we will be studying about the lichen planus, psoriasis, all those things. Okay, let's start with the first thing, that is your that is your psoriasis. So basically psoriasis is a autoimmune disorder. Okay, कैसा disorder है? It is a basically autoimmune disorder. What is the most common site where you will find psoriasis? कहाँ पर होता है most commonly? In the body which surfaces? Okay, so that would be mostly seen in the extensor surface. This would be mostly seen in the extensor surface. Okay, most common type of psoriasis, I have already told you. There is a word, and the meaning of that word would be उसका मतलब क्या होता है, most common. Okay, so that is your psoriasis vulgaris. Most common type of psoriasis will be psoriasis vulgaris. This is the most common. Okay, now we are having a mnemonic, that is polish. What are the things that we are going to see in the psoriasis, lichen planus? These are the very important topics. There's no exam without these questions. Okay, just like diabetes and hyperthyroidism, without that there is no question. Just like that, psoriasis is very important. Okay, so we are having P. You can remember, for P for there will be pitting. What you will see pitting. Okay, O for there will be oil drop sign. We have seen oil drop sign, right? Most characteristic lesion, we have seen the oil drop sign, right? Next thing, O and L together will form the onycholysis. Onycholysis का मतलब क्या होता है? There will be damage in the nails. Okay. I for irregular. You can remember here, the pitting will be irregular over here. Pitting होती है nails के ऊपर, pitting होती है thimble nails. So the pitting will be irregular. Okay. Regular pitting will be seen in, important, regular pitting will be seen in which case? We have seen alopecia areata. In alopecia areata, there will be deep regular pitting. Okay, so pitting can also differentiate. Okay, so there will be deep regular pitting in the alopecia areata, but here we will be having irregular pitting. Okay, irregular superficial pitting. As for there will be subungual hyperkeratosis. ठीक है, तो psoriasis में क्या याद रखना है? psoriasis में just remember the mnemonic polish will be telling you all the important stuff. Okay, so there will be pitting, there will be oil drop sign, there will be onycholysis, there will be irregular pitting and subungual hyperkeratosis. क्या मतलब होता है subungual hyperkeratosis? अभी बताता हूँ, right? This one is your pitting. Look here, guys, this is the nail, and you can see there is irregular pitting. Okay, irregular pitting हो रहा है यहाँ पर. So this is irregular pitting. First thing. Second thing, we have already seen this one. This one is your oil drop sign. This one is your oil drop. This one is your oil drop sign. Okay, here there is damage in the nails. That is what is known as onycholysis. Okay, and these are the scales that we will find. Scale is a secondary lesion, right? So these are the scale that we will find. Okay, and the ring around the scale is known as worn off ring. इस ring को क्या बोलते हैं? Worn off ring. Worn off ring. They in psoriasis we will find silvery scales. Okay, silver color के scales मिलेंगे. These white scales that you are seeing, these are known as silvery scale, and the ring around them is known as worn off ring. और इसके ऊपर एक membrane होती है. There will be a membrane about it that is known as Buckley's membrane. कौन सी membrane बोलेंगे इसको? We call it Buckley's membrane. Very important, guys. Last year, two question from this one. Okay, this one is known as Berkeley's membrane. Berkeley's membrane में क्या होगा? There will be, when you try to remove that membrane, okay, when you try to remove that membrane, you will be finding pinpoint bleeding. Okay, so you will be finding pinpoint bleeding on removal of Berkeley's membrane, and that is known as which sign? That is known as Auspitz sign. कौन सा sign बोलते हैं इसको? We call it Auspitz sign. Okay, so what we have seen, we are having this scale. इसके आसपास क्या होगा? There will be a membrane that is known as there will be a ring that is known as worn off ring, और worn off ring के ऊपर क्या होगी? There will be a membrane that is known as Buckley's membrane, and when you try to remove that membrane, what will happen? There will be appearance of pinpoint bleeding spots. Okay, there will be appearance of pinpoint bleeding spots, and that is known as my guys, that is known as Auspitz sign. कौन सा sign बोलेंगे इसको? Auspitz sign बोलेंगे इसको, right? Now let's talk about the certain important points about the histopath of the psoriasis. Okay, histopath of the psoriasis. I have already told you what will happen in the stratum corneum. सबसे ऊपर वाली लेयर में क्या होगा? सबसे ज़्यादा केराटिन होगा. Okay, so what you will see here, you will see hyperkeratosis. बहुत सारा hyperkeratosis will be there. Okay, second thing, these are retiridges. Retiridges मतलब the part of epidermis which is going into the dermis. So here, look here, these are elongated बड़ी बड़ी retiridges है, club shaped retiridges. Okay, कौन से retiridges मिलेंगी? Club shaped retiridges, right? Next thing, thin suprapapillary epidermal plates will be there, and very important, parakeratosis. I have already told you what is the meaning of parakeratosis, है ना? अपन ने पढ़ा था. Parakeratosis means there will be retention of nucleus. There will be retention of nucleus in which layer? In stratum. कौन सा में नहीं होना चाहिए? इन stratum corneum में न्यूक्लियस नहीं होना चाहिए. But if there is a nucleus in the stratum corneum, we call it parakeratosis. Okay, so here, look here, यहाँ पर ब्लू डॉट होना चाहिए? नहीं होना चाहिए. ब्लू डॉट इज रिप्रेजेंटिंग न्यूक्लियस. ओके, बट व्हाट वी आर सीइंग हियर देयर इज अ ब्लू डॉट्स. ओके, सो ब्लू डॉट्स आर द इंडिकेटिव ऑफ, blue dots are the indicative of nucleus, right? So in parakeratosis, what will happen? There will be retention of nucleus. Okay, next thing, what we have seen, parakeratosis, we have seen the mnemonic P for psoriasis. What we are studying right now, we are studying psoriasis. Okay, that is why we need to connect things. Okay, next thing, we have seen the spongiform pustules of Kogos, and I have already told you this is the Kogos pustule. Okay, what else we have seen? We have seen the Munro microabscess in stratum corneum. There will be accumulation of WBCs in the stratum corneum, and that is known as Munro's microabscess. What we have seen, M के साथ में P जाएगा, P के साथ में M जाएगा. Okay, so Potterier's microabscess will be seen in Mycosis fungoides, and this one Munro's microabscess will be seen in psoriasis. Okay, तो दिस इज योर सोरियासिस. व्हाट वी हैव सीन, कोगोज पस्टूल हम लोगों ने देखा था सोरियासिस में, मुनरो माइक्रोएप्सिस हम लोगों ने देखी थी सोरियासिस में, पैराकेरेटोसिस वी हैव सीन इन सोरियासिस, हाइपरकेरेटोसिस वी हैव सीन इन सोरियासिस, एंड व्हाट वी हैव सीन इंपॉर्टेंट, दैट इज क्लब शेप रेटरीजेस. बड़ी बड़ी रेटरीजेस होंगी, एंड व्हाट विल हैपन, there will be dilated blood vessels. Okay, there will be dilated blood vessels. ये दिख रही है dilated blood vessels. Okay, so this is about the psoriasis. Okay, अगर psoriasis में I have told you there will be silver color scaling. Okay, what will happen, अगर scaling के साथ में pus है, ओके, स्केल्स के साथ में अगर पस है, स्केल्स दिख रहे हैं अलोंग विद पस, so what we call it, scales along with pus, we call it pustular psoriasis. Okay, pustular psoriasis बोलेंगे. Generally I have told you the psoriasis will present on extensor surfaces. Okay, psoriasis कहाँ पर होगा, extensor surface पे होगा. But right now look here, the psoriasis is present in the flexor surface, and that is why it is known as inverse psoriasis. Okay, इसको inverse psoriasis बोल देंगे. Next one is your psoriasis in pregnancy. इनके नाम पता कर लो. The psoriasis in pregnancy is known as impetigo herpetiformis. Impetigo herpetiformis is just a fancy term for the psoriasis in pregnancy. Okay, look here guys, this one is your scalp psoriasis. Scalp psoriasis, you can see silver white lesions. Okay, and this one is your gutta like structures, you can see in the guttate psoriasis. This is your guttate psoriasis, and this is red structures along with the scales, so that is there will be erythema, so that would be erythrodermic psoriasis. Okay, erythrodermic psoriasis. So these are the different kind of psoriasis that we have seen. Okay, this is pustular psoriasis. We can remember the drugs also. Just write down, for pustular psoriasis the drug of choice would be, write down, just write down, the drug of choice would be acitretin. The drug of choice for pustular psoriasis would be acitretin. Okay, in guttate psoriasis, remember guys, guttate psoriasis is after upper respiratory tract infection. Okay, it is generally associated with upper respiratory tract infection. Okay, so how we will treat the URTI, that would be your antibiotics. We can use antibiotics here. Okay, inverse psoriasis or flex, this one is your flexural psoriasis. For this one we can use a drug that is methotrexate. Generally these are your autoimmune conditions guys, these are your autoimmune conditions. Psoriasis is an autoimmune condition, so how we try to treat it, we will try to give steroids first. Okay, in mild cases we will try mild steroids. Okay, but if there is no relief, then we can add you can know, we can add methotrexate. Okay, methotrexate. In impetigo herpetiformis we cannot use methotrexate because the patient is pregnant, so we can use another drug, that is steroids. Okay, we can also use cyclosporine. We can also use cyclosporine. Okay, in erythrodermic psoriasis also we can give methotrexate. Okay, so these are the treatment of the psoriasis. Okay, these are the treatment of the psoriasis and important points of about the psoriasis. From these two slides you can expect two questions, at least two questions can be done from this, right? So the next one is your lichen planus. Lichen planus, just remember, it is a 6P disease. It is a 6P disease. What are the 6P that you need to remember? First one, they will be plain, they will be purple, they will be plain top. Psoriasis in lichen planus, there will be plain, purple, plain top, pruritic, very important, pruritic matlab itching. Okay, and papules. So there will be plain purple, plain top, pruritic, papules, and the sixth P will be pterygium. Okay, pterygium, I have already told you, in lichen planus the most characteristic finding would be pterygium. Okay, and pterygium is nothing but your proximal nail fold is bisecting the nail into two parts. This is your proximal nail fold, and this is bisecting the nails into two part. So that is your pterygium, and it is characteristic finding of lichen planus. Okay, and these are the purple, these are your plain purple polygonal pruritic papules. Okay, these are your plain purple polygonal pruritic papules. And ठीक है, ये plain top होते हैं. Okay, what else we can see? We can see Wickham stria. Wickham stria, we can see reticular lacy pattern, we can see reticular lacy pattern, reticular lacy pattern in mucosa, in oral mucosa, in oral mucosa, मुंह के अंदर ऐसा लीजन दिखा है, that is known as Wickham stria. इसके ऊपर भी क्वेश्चन है, multiple times asked. Okay, so these are the important pointers about the lichen planus. These are the important things that you should be remembering. Okay, now let's see the histopatho part of the lichen planus. What are the things that you will see here? You will be seeing hyperkeratosis. Okay, second thing, you will find hypergranulosis in psoriasis. You will be only finding hyperkeratosis. Here you will find hypergranulosis as well. Okay, here the red ridges are sawtooth like. Look here guys, these are your red ridges and these are sawtooth like appearance. इनकी appearance कैसी है? Sawtooth like appearance. Tooth appearance. Okay, what we have seen in psoriasis, the red ridges are club shaped, lambi lambi badi badi red ridges, right? Here you can find lichenoid infiltrate. That is not at all much important. The much important thing is the perfect max joseph cleft. यहाँ पर there is a space between these two layers and that is known as max joseph cleft. Okay, and cavate body will also be seen in the cases of lichen planus. Okay, so these are the differentiating features. These are the differentiating features that you will find between psoriasis and lichen planus. Okay, sawtooth appearance of red ridges. There you will find the club shaped red ridges. यहाँ पर red ridges कैसी है? These are like club shaped. Okay, hypergranulosis will also be seen over here. Okay, so these are the two important things, very important guys. Next one is your isomorphic phenomena. Isomorphic phenomena का मतलब क्या होता है? Iso मतलब same, morphic मतलब morphology. Okay, so what will happen when you try to scratch or someone is having disease? Okay, this is also known as Koebner's phenomena. This is also known as Koebner's phenomena. So what will happen over here? Suppose someone is having like someone is having psoriasis. Okay, someone is having psoriasis, lichen planus or vitiligo. These are seen in three conditions. These are PLV, that is psoriasis, lichen planus, and third one is vitiligo. So what will happen? Suppose someone is having the disease. Now what will happen when he try to scratch or there is some kind of trauma, then what will happen? There will be appearance of same type of lesion on that part. Okay, जहाँ पर भी trauma होगा वहाँ पर क्या होगा? वैसा का वैसा ही lesion हो जाएगा. So that is known as Koebner's phenomena. That is known as isomorphic. Iso मतलब same morphology का lesion हो जाएगा वहाँ पर, and this is known as true Koebnerization. Okay, true Koebnerization. We are also having false Koebnerization. False Koebnerization can be seen in the cases of like warts. That can be seen in the cases of warts. That can be seen in the cases of molluscum contagiosum. So basically these are not true Koebnerization. Molluscum contagiosum. यहाँ पर क्या होता है ना, देर विल बी ऑटो इनोकुलेशन. क्या होगा? जहाँ से आप उठा के जहाँ पर स्क्रैच करोगे वहाँ पर बिकॉज ऑफ ऑटो इनोकुलेशन ऑफ ऑर्गेनिज्म जो अपना वायरस है वो दूसरी जगह आके अटैच हो जाएगा एंड दैट वुड कॉज द false carbonization. Okay, that will cause the false carbonization. That would be seen in the molluscum contagiosum and warts. Okay, यहाँ पर true होगा, यहाँ पर false होगा. What is this structure? What are these things? So you will find in your extensor surface near the elbow, you will find multiple small dots, right? So these are known as lichen nitidus. These are known as lichen nitidus. These are known as lichen nitidus. Multiple small dots over your extensor around your elbow. That is known as lichen nitidus. Okay, lichen nitidus, also known as mini lichen. इसको दूसरा नाम क्या है? Also known as mini lichen. Okay, that would be found on which surface? That is your extensor surface. And what is the characteristic appearance that you will see over here? That is known as this characteristic appearance that has been asked in examinations. That is your ball in claw appearance. Ball in claw appearance. इसको क्या बोलते हैं इस appearance को? We call it ball in claw appearance. Okay. So these are the important pointers. Okay. Now let's talk about pityriasis. These are pityriasis. The meaning of pityriasis will be scaling. मतलब क्या होता है pityriasis का? The meaning of pityriasis will be scaling. Meaning क्या होगा pityriasis का? Scaling will be there. Okay, what you will see here, this is pityriasis rosea. In pityriasis rosea, what will happen? There will be first there will be formation of a there will be formation of a single patch. Now you know what is a patch. Patch is a flat lesion, right? More than 1 centimeter. So there will be formation of small patch that is known as mother patch. Mother patch, also known as herald patch. Also known as herald patch. That is known as mother patch, also known as herald patch. Okay, so what will happen, there will be formation of a mother patch. Now what will happen, from this mother patch, what will happen, there will be formation of other patches as well, and they will be in the form of a Christmas tree. Okay, they will be in the form of a fir tree or Christmas tree appearance. They will be giving rise to fir tree appearance or christmas Christmas tree appearance. They will be giving rise to fir tree or Christmas tree appearance. Okay. And what kind of scales you will find over here? You will find cigarette paper scales or collar rate of scales. You will find collar rate of scales. You will find collar rate of scales cigarette cigarette paper scales. You will find collar rate of scales or cigarette paper scales. Okay. Silver white scales, you will I have clubbed multiple scales over here. Okay, so that would be easy for you to revision. So these are your silver white scales. Silver white scales कहाँ पर देखे थे हम लोगों ने? We have seen in which disease? Answer me guys. We have seen in psoriasis. Okay, fish like scaling. We have seen fish like scaling in which disease? We have seen in ichthyosis. Ichthyosis. Ichthyosis का मतलब ही fish like होता है. ठीक है. Greasy scales. Greasy scales will be seen in which disease guys? That is your seborrheic dermatitis. Seborrheic dermatitis. Okay, seborrheic dermatitis is nothing but your dandruff, right? Brainy scale or rice grain scale will be seen in pityriasis versicolor. Okay, so these are the important scales that you should be remembering. All these has been asked in your previous examination. This is very important table, right? So brainy scale or rice grain scale will be seen in pityriasis versicolor. Okay, pityriasis rosea, you will find collar rate of scale or cigarette paper scale. Repeat with me. Okay, silver white scale will be seen in which cases? In the cases of psoriasis. Okay, greasy scales will be seen in the cases of seborrheic dermatitis, and in pityriasis versicolor you will be finding brainy scales or rice grain scales. Okay, so these are the important pointers that you should be remembering. Okay, now let's talk about certain infections guys. Now we will be discussing about the infections. So we are having bacterial, viral, fungal and parasitic infections. So we will be discussing one by one about everything. Okay, so the first one is your bacterial infection. In bacterial infection, the first one would be erythrasma पे multiple times question है, बहुत ज़्यादा important है. Just look here. Okay, so एरिथ्राजमा, व्हाट इज द कॉजेटिव एजेंट फॉर एरिथ्राजमा? कौन सा बैक्टीरिया है जिसकी वजह से एरिथ्राजमा होता है? दिस इज द वेरी इंपॉर्टेंट क्वेश्चन. ओके, दैट इज योर कोराइनी बैक्टीरियम माइनूटिसिमम. Corynebacterium bacterium minutissimum is the causative agent. Okay, and when you try to look under the wood lamp examination, basically होता क्या है, this Corynebacterium minutissimum will be releasing keratolytic enzymes. Okay, that would be releasing keratolytic enzymes. और keratolytic enzymes मतलब क्या होगा? That would be digesting the keratin, right? And when you look under wood lamp examination, when you try to look under wood lamp examination, when you try to do wood lamp examination, what you will find guys, you will find this structure that is known as this appearance that is known as coral red appearance. That is known as coral red appearance. What kind of appearance you will see? Multiple times asked question. The coral red appearance you will see in erythrasma. Erythrasma is due to Corynebacterium minutissimum, and that would be producing a keratolytic enzymes. Okay, that would be producing keratolytic enzymes. Okay, second thing is your ichthyma. Ichthyma we are having multiple types. Okay, ichthyma pyogenicum. Pyogenicum मतलब pyogen से होगा, streptococcus pyogens. Okay, ichthyma gangrenosum is due to pseudomonas. Ichthyma gangrenosum is due to pseudomonas, and contagiosum बहुत ज़्यादा contagious होता है, that is due to a virus, that is your parapox virus. Okay, so this is the bacterial infection. Okay, now let's talk about impetigo. Impetigo herpetiformis is psoriasis in pregnancy. Okay, now here we will talk about two types of impetigo. First one is your bullous impetigo, second one is your non-bullous impetigo. Okay, we are having different causative agent for both the things. Okay, in non-bullous impetigo you will find this very important thing, that is your honey colored crusting. Honey colored crusting, very important. Honey colored crusting is seen in नॉन बुल्लस इम्पेटिगो. नॉन बुल्लस मतलब यहाँ पर क्या होगा, देर विल बी नो बुल्ला. बुल्ला मतलब क्या था, वी हैव सीन देर विल बी नो फ्लूइड फील्ड लीजन, राइट. सो दिस इज अ नॉन बुल्लस इम्पेटिगो, एंड द causative agent for this non bullous impetigo would be staph or strepto. Yes, it can be due to both, but the strepto is the most common cause. Streptococcus followed by staph aureus. Okay, streptococcus is the most common cause. Okay, bullous impetigo, look here, यहाँ पर bulla था, then what will happen, the bulla will rupture and there will be a normal excoriation here, right. So there will be normal erosion over here, right. So that is your bullous impetigo, and the causative agent for bullous impetigo would be staph aureus. Very important, the causative agent for bullous impetigo would be staph aureus. दोनों में differentiate कर लोगे. Okay, नेक्स्ट थिंग इज योर सेलुलाइटिस वर्सेस एरिसिपिलस. ओके, सेलुलाइटिस और एरिसिपिलस देखने में दोनों एक जैसे लगते हैं, बोथ ऑफ देम आर लुकिंग सिमिलर, बट देर इज अ हेल लॉट ऑफ डिफरेंस, राइट. सो एरिसिपिलस विल बी, look here, cellulitis. What is the meaning of cellulitis? There will be inflammation of cells. Okay, but the most important thing, that is, it is a deep, it is a deep infection that would be going up till your paniculus. Paniculus matlab that is your hypodermis. So it is deep, going till, going till hypodermis. Okay, here the lesion will be, it is diffuse kind of lesion. Okay, here diffuse will, here there will be diffuse kind of lesion. Okay, this one will be sharp, here will be sharp demarcations, and this one will be, erysipelas will be as for superficial lesion. एरिसिप्लिस विल बी सुपरफिशियल. ओके, एरिसिप्लिस ऊपर ऊपर होगा, सेलुलाइटिस डीप तक होगा. व्हाट इज द मोस्ट कॉमन कॉज ऑफ सेलुलाइटिस? टेल मी, what is the most common cause of cellulitis? The answer would be staph aureus. Staph aureus, the most common cause of cellulitis would be staph. Okay, while erysipelas is caused by group A beta hemolytic streptococci. Okay, that is your streptococci, group A beta hemolytic streptococci. Okay, so this is the difference between cellulitis and erysipelas. Now let's talk about fungal infections. Okay, in fungal infection, first thing I have already told you, the meaning of pityriasis will be scaling. Okay, so here you will find hypo and hyperpigmented rash, that is your pityriasis versicolor. What is the causative agent? What is the causative agent for pityriasis versicolor? That is your, very important guys, malassezia, malassezia furfur or malassezia globosa. These are the two causative agents. Okay, these are two different fungus that would cause pityriasis versicolor. Versicolor matlab different color, there will be hypo and hyperpigmentation. Okay, now most common site would be trunk. Okay, when you try to look into wood lamp examination, what you will find in the wood lamp examination here, wood lamp examination will be showing you apple green color. What color uh, it will be showing you? It will be showing you apple green color. And when you try to look into the microscopy, guys, you will find a very characteristic appearance, that is spaghetti and meatball appearance. Spaghetti and meatball appearance. Spaghetti and meatball appearance, and that is very important. Okay, that is very important, spaghetti and meatball appearance. And you can also call it banana and grapes appearance. You can also call it banana and grapes appearance. Banana and grapes appearance. Okay, so how you are going to treat this infection? You are going to treat this infection with the help of a drug, that is selenium sulfide. What you can give for treatment purpose, you can give selenium sulfide. Selenium sulfide. You can also use different kind of azoles. Okay, you can also use azoles. What are azoles? Like ketoconazole, fluconazole, all those azoles. Okay, so you can use that. Next one is your pedra. Pedra is of two types, two important. First one is your black pedra. Second one is your white pedra. So black will be hot. Okay, whenever you wear black you look hot, so black will be hot. Okay, so that is due to pedra horte. I remember like that, that is due to pedra horte. Okay, and white pedra is due to trichosporon बिजली. बिजली, बिजली कैसी होती है? बिजली मतलब लाइट, लाइट इज वाइट. ओके, सो ट्राइकोस्पोरॉन बिजली. Okay, trichosporon bijili or black pedra is due to pedra horte. Okay, now next is your dermatophytes. Okay, what are the different kind of dermatophytes that we are having? We are having trichosporon, sorry, we are having trichophyton, we are having epidermophyton, we are having microsporon. Okay, so whenever the dermatophyte is including all three structures, what we have seen, all three appendages, like if it is infecting your hairs, if it is infecting your nails, if it if it is infecting your skin. Okay, till now what we have seen, if it is infecting everything, that is trichophyton. Okay, in epidermophyton, e के बाद में h आता है, remember guys, so it won't be affecting hairs. Hairs are spared. Okay, hairs are spared, so what it will affect, it will affect your nails and your skin. Okay, your skin or your nails, you can remember, like epidermis को affect करेगा and nails को affect करेगा. Okay, and for nails, E for epidermis, so it would be affecting skin, it would be affecting your nails, but it won't be affecting your hairs. Okay, and microsporon के बाद में N आता है, M के बाद में N आता है, so it won't be affecting your nails. Okay, so what it will affect, it would be affecting your hairs and it would be affecting your skin. This is how you should be remembering. Okay, this is the just for the remembering purpose. Okay, so these are the three organisms, and these are the three types of dermatophytes. Okay, so let's talk about the tinea infection. Tinea, very very important guys. If this infection, if in the question, when you are trying to do the question, if in the question it is written painful, it is written somewhere, it is written painful, tender. If it is these are the buzzwords guys. If just look for the buzzwords, if you know, if you can identify those buzzwords, you can easily solve the question, right? You can easily get the marks. So these are painful, tender, known. These are painful, tender, bogey, swelling, bogey. These are painful, tender, bogey, swelling. Okay, if it is written painful, tender, bogey, swelling, and this image is given, that is your tinea, that is your carrion guys, that is your carrion. Okay, that is your carrion. Okay, carrion. What is the causative organism for carrion? Remember guys, causative organism for carrion would be tinea mentagrophyte, tinea mentagrophyte, or tinea verrucosum. So these are the causative organisms uh, for carrion. Okay, this is your carrion. Next one is your, this one is your scutula. This one is your scutula or favus, you can call favus, and this is due to tinea snollen. This is due to tinea snollen. Okay, next one is your black dot. These are your black dots. These are your black dots. Okay, and this one is your gray patch. This one is your gray patch. Gray patch. How you are going to treat the tinea capitis infections? For tinea capitis infection, you can use a drug, that is griseofulvin, right? You can use a drug, For the treatment purpose, you can use a drug that is cryopulvin, 10 to 20 mg body weight के हिसाब से देना है. That is your cryopulvin. Okay. Now let's talk about some more tinea. Okay. So that is your tinea cruris. That is your tinea cruris. Okay. This one is your tinea corporis. This one is your tinea corporis, and this one is your tinea pedis. Tinea pedis, also known as athlete's foot. Athlete's foot. This is also known as athlete's foot or tinea pedis. Okay. Tinea में क्या होगा? You will be finding center clearing. Okay. In tinea infection, you will be finding center clearing. Okay. In lupus vulgaris, remember guys, it is the most common cutaneous form of TB. Okay. Then what you will find, there will be central scarring. बीच में scarring होगी. And central crusting is a feature of leishmania. Okay. So if there is a this is a, देखा होगा ना तुम लोगों ने, रिंग वर्म देखा होगा. सो व्हाट विल हैपन, देयर विल बी सेंट्रल क्लियरिंग अगर दिखा रखा है, सो दैट इज अ टीनिया इन्फेक्शन, दैट इज अ फंगल इन्फेक्शन, राइट. And if there is a scarring in the center, that would be your TB. Okay. Lupus vulgaris मतलब most common type of TB, right? Most common type of cutaneous TB. Okay. Skin TB. Write down about this. What is this, guys? Very important. Every exam question is coming from these pictures are very mandatory to understand. Okay. So this is the case of sporotrichosis. This is the case of sporotrichosis, and this is due to sporothrix shanki. This is due to sporothrix shanki, and this is given. Look here. This is basically nothing but the lymphocutaneous spread. ये क्या हो रहा है यहाँ पर, क्या दिखा रखा है? The spread would be lymphocutaneous. Okay. So how it will be spreading? The spread would be lymphocutaneous. The spread would be lymphocutaneous. Okay. This is also known as, guys, this is also known as Rose Gardner's disease. इसका दूसरा नाम क्या है? Rose Gardner's disease. What is the other name for this? Rose Gardner's disease. Okay. And these bodies are known as asteroid bodies. इन bodies को क्या बोलते हैं? Asteroid bodies. These are the asteroid bodies. Okay. This is also known as Valentine disease because Valentine के आसपास क्या होता है? People will pluck the rose. Okay. रोज प्लग करेंगे तो क्या होगा? उनको कांटा लगेगा, और कांटा लगने की वजह से क्या होगा? दे विल बी डेवलपिंग स्पोरोट्राइकोसिस. हाउ यू आर गोना ट्रीट दिस सिचुएशन? यू आर गोना ट्रीट दिस सिचुएशन विद द हेल्प ऑफ अ ड्रग दैट इज इट्राकोनाजोल. क्या दोगे? इट्राकोनाजोल. Okay, so these are the important points about this sporotrichosis. We will be studying in microbiology. So micro का part है, but it is always connected with the derma as well. Okay, so this is the lymphocutaneous spread, right? This one is your chromoblastomycosis. Very important. These questions are very important. This is your chromoblastomycosis. क्यों बोलते हैं chromoblastomycosis? Because देखो यहाँ पर multiple color का दिख रहा है, multiple colors, right? So it is a very colorful fungus. Okay. And what are these bodies? These are known as multiple names for these bodies. Very important. These are known as copper penny bodies. These are also known as medlar bodies. और क्या बोलते हैं इनको? Medlar bodies. Copper penny bodies, medlar bodies. These are also known as sclerotic bodies. What else? These are also known as murulliform bodies. So these are the multiple names of the same thing. So these are murulliform bodies. Okay. How you're gonna treat this situation? Again, for chromoblastomycosis, also you are gonna use itraconazole. You're gonna use itraconazole for chromoblastomycosis as well. Okay. So sporotrichosis देखा, sporotrichosis में भी क्या किया था हम लोगों ने? itraconazole दिया था. Here also we are using itraconazole. Now let's talk about the parasitic infection. Okay, parasitic infection. इसको देख के क्या लग रहा है? First thing, what you are suspecting, what is the infection? So that is nothing but your scabies, right? Scabies. And what is the most common site for scabies? That is your circle of Fabra. दिस इज द एरिया दैट इज नोन एज सर्कल ऑफ हैब्रा, और यहाँ पर सबसे ज़्यादा स्केबीज होता है. दिस इज अ वाटर वॉश डिजीज, राइट. सो व्हाट इज द पॉजिटिव एजेंट हियर, दैट वुड बी योर सार्कोप्टिस स्केबीज. ओके, ये माइट होता है, दैट वुड बी कोजिंग इचिंग. ओके, बहुत ज़्यादा इचिंग होती है. इट इज़ ऑल्सो नोन एज प्रिंस itch disease. It is also known as prince itch disease, or it is also known as 7 years itch disease. इतनी ज़्यादा itching होती है. ओके, and what are the characteristic finding that you will see burrows. ओके, यहाँ पर क्या देखने को मिलेगा आपको, you will be seeing burrows. ओके, you will be seeing burrows, and these burrows are present in stratum corneum. In the stratum corneum you will be seeing these burrows. ओके, इनके अंदर क्या होता है, there will be scabies. Okay, there will be scabies mite. What is Norwegian scabies? This is the worst prognosis, guys. This is the worst prognosis. Worst prognosis. And how you are going to treat this, along with the ivermectin. You can give ivermectin in this situation. Otherwise, the drug of choice for scabies would be 5% permethrin. The drug of choice would be 5% permethrin. बाकी जगह पे हम लोग क्या देंगे, we will be giving 5% permethrin, but here we can use ivermectin. Okay, ivermectin. Next thing, burrows are the most characteristic lesion. These are the most characteristic lesion. Burrows are the most characteristic lesions. Okay, so this is about the scabies, right. कहाँ पर होता है, मतलब जनरली दे विल बी सीन इन द इंटरट्रिजनस एरियाज. ओके, नेक्स्ट थिंग विल बी, दिस इज़ योर पेडिकुलोसिस. दिस इज़ पेडिकुलोसिस और लाउस. ये अलग अलग जगह पे होती है. इफ़ दे आर प्रेजेंट इन द, if they are causing disease in the head, that is your head louse, and in the body, that is due to body louse. But in the pubis there will be crab louse. Okay, there will be crab louse in the body. And there the most characteristic lesion that you will see here, that is known as macula cerolia. That is known as macula cerolia. Okay, that is the most characteristic lesion that you will see in the cases of pediculosis. How you're going to treat this situation, how you're going to treat the pediculosis? Same drug, guys, that you used in scabies, just 1% of permethrin. Okay, 1% permethrin. 1% permethrin is the drug of choice. Okay, now let's talk about the viral infection. The first one that we are seeing here is molluscum contagiosum. The first one that we are seeing here is molluscum contagiosum. Molluscum contagiosum, how you are going to identify, this is the most characteristic lesion over here, that this is known as pearly white umbilicated क्यों बोलते हैं, there is a center in between, there is a dip in between. Okay, that is why it is known as pearly white umbilicated papules. That is why it is known as pearly white umbilicated papules. Okay, along with that, what will happen, we will find certain inclusion bodies. Okay, यहाँ पर क्या मिलेगा, you will be finding inclusion bodies. And these inclusion bodies, remember guys, are known as, very important, these are known as Henderson-Peterson bodies. These are known as Henderson-Peterson bodies. Okay, molluscum contagiosum, I have already told you, will be showing you the false cognerization. Okay, that is due to auto inoculation. Okay, auto inoculation of organism की वजह से होगा. And we will be seeing Henderson-Peterson bodies. How you are going to treat this situation? कैसे treat करोगे? So basically it is a viral infection, बच्चे में हो जाता है immunity कम होने की वजह से. So how you're gonna treat, you're gonna use TCA. You can use TCA. Okay, TCA. You can also give podophyllotoxins, and you can also use cryotherapy. Nowadays you can use cryotherapy. Okay, you can also use cryotherapy. What you will see here you will see false cognerization. Okay, false cognerization. Now let's talk about the HPV. HPV के लिए एक निमोनिक याद करते हैं, that is your DSP come eat a burger. Okay, बर्गर बहुत पसंद है तो DSP come eat a burger. Okay, so D for deep. Okay, so D for deep, S for superficial. These are basically words. Okay, these are basically words. So D for deep words, S for superficial, P for plain words, C for common words, E for epidermodysplasia variciformis, and A for anogenital words, and B for butcher words. अब कौन सा क्या करवाता है? So HPV type 1 will be causing deep warts, HPV type 2 will be causing superficial warts, HPV type 3 or 10 will be causing your plain warts, HPV type 4 will be causing your common warts, and HPV type 5 will be causing epidermodysplasia variciformis, that is tree means hand type. Okay, and HPV type 6 and 11 will be causing anogenital warts. Along with that, it will be causing laryngeal warts also, laryngeal wart. Okay, and 7 will be causing butcher's wart. Okay, and 16 and 18 you must have studied in your ops gynae. Okay, so that would be your cervical cancer they can cause. Okay, so these are the bacteria, these are the viral infections. Now let's talk about certain mycobacterial infection. First thing that we have already studied about mycobacterial infection is, first thing, mycobacterial infection, this is your lupus vulgaris. Lupus vulgaris, what is the meaning of vulgaris? That would be the most common. I have already told you guys that lupus vulgaris is the most common cutaneous TB. This is the most common cutaneous TB. Okay, mycobacterium TB, that is the most common. Okay, what you will see, you will see central scarring. I've already told you, you will see central scarring. Central scarring is the feature of TB. Okay, while central clearing is the feature of tinea infection, fungal infection, right? So that we have seen. This one is your scrofloderma. What is scrofloderma, guys? Scrofloderma is the second most common type of cutaneous TB. Second most common type of cutaneous TB. Okay, or you can say it is the most common type of TB, most common type of cutaneous TB in children. बच्चों में होता है, in children. How you're gonna see this is the test known as diascopy. इसको क्या बोलते हैं हम लोग? This is known as diascopy, and in diascopy what you will find apple jelly nodules. You will be finding in the diascopy, you will be finding apple jelly nodules. Okay, so this is about the mycobacterial infection. Okay, now let's talk about the leprosy. Leprosy is due to mycobacterium lepra. किसकी वजह से होता है leprosy? Mycobacterium leprae. Mycobacterium leprae, does it follow Koch postulate or does not follow Koch postulate? Tell me about like your microbiology information. So does it follow Koch postulate or it does not follow Koch postulate? And you can also tell me what is Koch postulate. Okay, so this is your mycobacterium lepra. We are having two types of leprosy. First one is your, we are dividing it into two types. First one is your paucibacillary, second one is your multibacillary. Okay, paucibacillary or multibacillary. In paucibacillary there will be 1 to 5 lesions, and in multibacillary there will be more than 5 lesions. Okay, when we talk about the nerve involvement, it can be 0 or 1 sometimes, but it will be more than 1 or 2 nerve involvement seen in the multibacillary. Okay, how we are going to treat the situation? We are going to treat the situation with the help of same drugs. Okay, दोनों में same drugs use में लेंगे, but the duration is different. Okay, so when we try to treat for the patient for the paucibacillary, we will be giving treatment for the 6 month, same treatment for the 6 month. But when we try to treat the patient of multibacillary, we will be giving the same treatment for 12 months. 12 महीने तक treatment देंगे. And in this treatment what will happen, one time we are giving rifampicin, that is 600 mg per month, and we are also giving clofazimine one time, that is 300 mg per month. Rest, these two drugs will be, the patient will be taking at home. Okay, so every 28 days or every 30 days the patient should come to the hospital, the patient should come to the clinic and he will be taking the drug 600 mg rifampicin and 300 mg clofazamine. Okay, D4 dapsone, D4 dapsone will be for the daily purpose, right? So that would be 50 mg daily clofazamine, along with that 100 mg dapsone. So that would be for 6 months for paucibacillary and 12 months for multibacillary TB, right? Multibacillary leprosy, right? So we are having lepra reaction. What will happen when the patient will take the drugs? जब अपना बंदा दवाई लेगा तो वो उसको क्या होगा, देर विल बी फॉर्मेशन और देर विल बी जनरेशन ऑफ सर्टन रिएक्शंस, राइट? तो पेशेंट के अंदर कुछ रिएक्शंस होंगी एंड दीज आर नोन एज लेप्रा रिएक्शंस. ओके, दीज आर नोन एज लेप्रा रिएक्शंस. ओके, तो लेप्रा रिएक्शन में क्या करना है? यू शुड स्टॉप द ट्रीटमेंट और यू शुड कंटिन्यू. Yes, you should continue the treatment. You should not stop the treatment. What we need to do, we need to add certain different kind of drugs to suppress the lepra reaction. Okay, treatment बंद नहीं करना है, right? So we are having type 1 lepra reaction and we are having type 2 lepra reaction. Okay, type 1 lepra reaction, type 2 lepra reaction. So what we need to do, look here guys, type 1 lepra reaction and type 2 lepra reaction, what we need to do, type 1 will be what type of hypersensitivity, so we need to make it 5. Okay, addition में हमको 5 बनाना है, तो type 1 would be type 4 hypersensitivity and type 2 would be type 3 hypersensitivity. समझ में आया? So that would be, we need to make the 5. Okay, second thing, अगर टाइप 1 लेप्रा रिएक्शन हो रही है, दैट इज अ टाइप 4 हाइपर सेंसिटिविटी, व्हाट वी नीड टू डू, वी नीड टू ऐड अ ड्रग दैट इज योर स्टेरॉइड्स, दैट इज योर स्टेरॉइड्स. ओके, हम लोगों को क्या करना है, वी नीड टू ऐड द ड्रग दैट इज स्टेरॉइड्स. इन टाइप 2 ऑल्सो वी कैन यूज स्टेरॉइड्स, but along with the steroids we can also use another drug that is thalidomide. And this is the question that has been asked like 3 to 4 times in the previous examination. Okay, thalidomide we can use in the type 2 lepra reaction. Okay, thalidomide, because there is a specific side effect from thalidomide and that is known as phacomelia. Or phacomelia, that is C limb deformities. Okay, बच्चों में क्या हो जाता है, C limb deformity. Okay, now, for leprosy, we are having a classification and that classification is known as Ridley-Joplin classification. इसका नाम क्या है? That is known as Ridley-Joplin classification. In Ridley-Joplin classification, what we have done, we have divided the leprosy into certain parts. Okay, so we are having TT, that is tuberculoid. We are having BT, that is borderline tuberculoid. We are having BB, that is borderline. BL, that is borderline lepromatous, or lastly we are having lepromatous leprosy. Okay, so we are having these 5 things. Okay, most important, we need to remember about BT type of leprosy, that is most common in India. BT type of leprosy is most common in India. Second thing, we will be finding satellite lesions here. Okay, कौन से lesions मिलेंगे? Satellite lesions. BB type of leprosy will present with inverted saucer shaped lesions. Okay, और ऑल्सो नोन एज जियोग्राफिकल लीशंस. ओके, ये बीबी टाइप में मिलेंगे. तो मोस्ट कॉमन लोग बीटी कौन देते हैं? इंडिया वाले लोग. तो ठीक है, मोस्ट कॉमन इन इंडिया दैट इज बीटी याद रख लो. सैटेलाइट गया था, सैटेलाइट याद रख लो. ठीक है, सो दिस इज योर लीजन. अलोंग विद द लीजन वी आर हैविंग, अराउंड द लीजन वी आर हैविंग अदर लीजन्स, दैट इज नोन एज सैटेलाइट लीजन. सो सैटेलाइट लीजन देख के पता कर लो कि व्हाट टाइप ऑफ लेप्रेसी इट इज. सो इट इज ए which type of leprosy, satellite कहाँ से गया था? That is from the India. In India the most common leprosy is BT type of leprosy. Okay, this one is a geographical lesion, or also known as geographical, or you can also call inverted saucer shape lesion. Okay, so this is inverted saucer shape lesion or geographical lesion. That is a feature of which type of leprosy? Answer me guys, that is BB type of leprosy. Okay, BB type of leprosy ho gaya. And this one is leonine facies. This one is leonine facies. This one is leonine facies. This one is your leonine facies. Okay, and what is this organism? This organism is 9-banded. This organism is 9-banded armadillo. This is 9-banded armadillo. I have asked you, does it follow Koch postulate or not? So in Koch postulate, Robert Koch said that every organism will grow in a culture media, but this cannot be grown in a culture media. So for growing Mycobacterium leprae, we are using a different organism, that is 9-banded armadillo. but in India we don't have nine banded armadillo. That is why we are using food paid of suckling new suckling mice. Okay, so that is what we are using. Okay, so these are the important pointers. Now let's talk about the STD. Okay, now let's talk about the sexually transmitted diseases. We have seen the bacterial infections. Okay, we have seen the viral infections, parasitic infections, and we have also seen the fungal infections. Okay, apart from this, now let's talk about the sexually transmitted diseases. Are you guys understanding? If you guys are having any doubts, just do let me know. Let me see. So can you please identify, just looking at the ulcer, can you please identify what kind of ulcer is this? Just looking at the ulcer, can you identify what kind of ulcer is this? So I will tell you the trick how to identify different kind of ulcers. Very good, Ro. Okay, I will be telling you the trick how to identify what kind of ulcers is this. Okay, so we are having, just look here guys, for 5 minutes, 5 to 7 minutes, please try to concentrate here. I will be telling you the most important information. Okay, if you understand this, that would be helpful for you in your OPD as well as in your life and in your exam as well. Okay, so these are different kind of ulcers that we are having. Okay, so start karte first. First thing, we are having HSV, that is your herpes simplex virus. Okay, herpes simplex virus is of two type: HSV1 above the waist, HSV2 below the waist. Okay. Second thing is your chancroid. The causative organism for chancroid would be Haemophilus ducrei. Haemophilus ducrei. Okay. Third one is your syphilis. The causative organism for syphilis will be Trypanoma pallidum. Next one is your donovenosis. The causative organisms will be Klebsiella granulomatis. And the last one is your LGV, and the causative organism will be chlamydia. Incubation period देख लो इनका, HSV 3 to 7 days, this one is 3 to 5 days. Syphilis 9 to 90 days, which is a spirochete. It also does not follow Koch postulate. Okay, ये भी grow नहीं करता. Next one is your donovenosis, that is 30 days, and the chlamydia would be 10 to 30 days. Okay, so first thing that you need to understand, अगर ऐसा कोई patient आ जाता है, if a patient is coming to you and you are the duty doctor, and you need to identify what kind of ulcer is this, and because different ulcers will be having different organisms and you need to treat differently. So how will you identify what is the method? So first thing that you need to see is the pain. Okay, so first thing that you need to see is the pain, whether the patient is having pain or not. Okay, whether the patient is having pain or not. If the patient is having pain, it can be two things. Either it can be HSV infection, or either it can be chancroid. Okay, it can be only two things. Painful will be two things. That can be either it can be herpes simplex virus, second thing would be chancroid. Okay, but if it is painless, it can be three things. If it is painless, then it can be three things. It can be syphilis, it can be donovenosis, it can be LGV. Okay, second thing that you need to remember, that is, in HSV there will be multiple ulcers. In chancroid also there will be multiple ulcers. But if there is a single ulcer will be seen in syphilis, and donovenosis also single ulcer. Okay, and LGV, remember guys, lymphogranuloma venereum, the ulcer is very transient. जब तक patient आपके पास में आएगा hospital, the ulcer will be gone. Okay, so ulcer is very transient, so you won't find any ulcer, right? So basically you need to treat between these two. ठीक है, इन्हीं में से पता लगाना है. Between these four you need to identify. How you will identify? First thing, first thing, और first thing, that is, what is the meaning of herpes? Herpes का मतलब होता है grouped. The meaning of herpes would be grouped. The meaning of herpes will be grouped. So here you will be finding grouped vesicle. Here you will be finding grouped vesicle with polycyclic erosion. Polycyclic erosion. अगर ग्रुप्ड वेसिकल दे रखी है, वेसिकल मतलब छोटी छोटी, less than point, zero point 0.5 centimeter, that is your vesicle, right? So grouped vesicle with polycyclic erosion, that would be your herpes. ठीक है, ऐसे पता चल जाएगा, that would be your herpes. First thing, it is painful. Second thing, it is multiple बहुत सारी है, multiple herpes का मतलब भी multiple होता है, multiple grouped. Okay, so herpes is multiple grouped vesicle with polycyclic erosion, that is herpes. Okay, second thing, और कहाँ पर मिल रहे हैं मल्टीपल अल्सर्स? मल्टीपल अल्सर्स आर फाउंड इन शैंक्रोइड. ओके, शैंक्रोइड में यू विल ऑल्सो फाइंड मल्टीपल अल्सर. Synchroid will, you will also find multiple ulcer, but look here the edges are undermined. Look here, the at the edges guys, these are the undermined edges. Okay, multiple ulcers to have, but they are having undermined edges. So these are the certain pointers that you should be remembering. Agar undermined edges they रखा है, then your that would be your chancroid. Okay, third thing will be syphilis. Syphilis painless. Okay, do cry मतलब ड्यू क्राई ऐसे याद रख लो, डू क्राई, सो दैट वुड बी पेनफुल. ओके, हेमोफिलस ड्यू क्राई वुड बी पेनफुल. ट्रिपेनोमा पैलिडम सिफिलिस, सिफिलिस मतलब पेनलेस. ओके, दैट वुड बी पेनलेस. इसमें क्या याद रखना है, यू नीड टू रिमेंबर द बस वर्ड्स, दैट इज रबरी और शॉर्टी. ओके, सिंगल अल्सर होगा, वी ऑलरेडी नो. अगर रबरी और शॉर्टी, अगर क्वेश्चन में दे रखा है रबरी और शॉर्टी लिम्फ नोड्स, आंसर वुड बी सिफिलिस. आंसर वुड बी सिफिलिस. प्राइमरी सिफिलिस, सेकेंडरी सिफिलिस, अर्ली लेटेंट, लेट लेटेंट, टर्शरी सिफिलिस और न्यूरोसिफिलिस, ये 5 तरीके के होते हैं. ठीक है, तो दैट वुड बी योर सिफिलिस. ओके, हियर हाउ टू डिफरेंशिएट बिटवीन पेनलेस सिफिलिस है या फिर ये है डोनोवेनोसिस है, कैसे पता चलेगा? लुक हियर, इन डोनोवेनोसिस यू विल बी फाइंडिंग beefy red ulcer, beefy red ulcer which bleed on touch. आप जैसे ही टच करोगे, when you will try to touch the ulcer, that would be bleeding. Okay, so this is how you are gonna differentiate between syphilis and donovanosis. First thing, you will see the pain. If there is pain, what will happen? Pain can be in the two situation. First one would be HSV. Second one would be this one, Haemophilus ducreyi. Okay, ducreyi. So these two things can happen. Okay, that is your chancroid. That is your chancroid. तो painful will be two things, HSV and chancroid. HSV की जब भी बात होगी, whenever we will talk about HSV, what will happen? There will be multiple grouped vesicle. Multiple grouped vesicle अगर मिल गया तो herpes है. Herpes HSV type 1 यहाँ पर भी होता है around the lips, that would be also multiple grouped vesicle, ऐसा ही दिखेगा. Okay, so multiple grouped vesicle you can easily identify just by looking at the thing. Okay, second thing, multiple ulcers तो है but undermined edges है. Multiple ulcers are there but undermined edges are there, that would be your chancroid. Okay, these are two painful things. Third thing, these are painless, guys. So syphilis will be painless and this one is also painless. Donovanosis will also be painless. Okay, इसमें क्या होगा? Here you will be finding beefy red ulcer which will be bleeding on touch. जैसे ही टच करोगे that would be bleeding. Okay, single beefy red ulcer that would bleed on touch. Okay, तो पता चल जाएगा डोनोमेनोसिस है. एंड LGV में तो अल्सर दिखते ही नहीं है. LGV में there is no ulcer, there will be transient ulcer. Okay, so this is how you are going to identify. इसको एक बार और देख लेना, you will be easily understanding this, right? Next thing is your STD kits. What are the STD kits that we are having? Okay, तो पता है क्या करना है? You just need to look for the discharge. Okay, so whether the patient is having urethral discharge कहाँ से आ रहा है? urethra से आ रहा है. तो it can be two situation, either it can be gonococcal infection, either it can be non gonococcal infection. Gonococcal में most common is gonococcal, so it can be gonococcal or it can be chlamydia में there will be mucoid discharge. कैसा discharge होगा? mucoid. gonococcal में there will be purulent discharge कैसा होगा? there would be purulent discharge. Okay, so how you are going to treat this situation? देखो, if it is a bacterial infection you need to give antibiotics. We are having certain STD kits. हम लोगों ने क्या किया, बहुत सारी STD kits बना ली. And when the patient come to us, what we need to do, जब भी पेशेंट आएगा व्हाट वी नीड टू डू, वी नीड टू सी द कलर ऑफ द किट्स, सिम्टम देखना है और किट पकड़ा देनी है, ठीक है। वी आर हैविंग एसटीडी क्लिनिक्स नाउ, पीएसएम से क्वेश्चन आ सकता है, वी आर हैविंग एसटीडी क्लिनिक्स नाउ, सो व्हाट वी नीड टू डू, वी नीड टू लुक फॉर द सिम्टम्स। So the symptom is we are having discharge from the urethra. So it can be gonococcal discharge, it can be non-gonococcal. So अगर gonococcal है तो we are giving third generation cephalosporin, that is a broad spectrum antibiotic, that is ceftriaxone. Along with that I am giving a azithromycin. Azithromycin is a macrolide. Okay, so दोनों से क्या होगा, that would be resolved. Okay, in mucoid I can use doxycycline along with the azithromycin. So what I can give azithromycin along with the cefixime, ठीक है। तो किट 1 बना दी, किट में क्या किया, एजिथ्रोमाइसिन दोनों में काम में आ जाती है, तो वी आर गिविंग एजिथ्रोमाइसिन along with that ceftriaxone is an injectable drug, right? So we can give broad spectrum cephalosporin, that is your cefixime. Cefixime orally दे सकते हैं यार, right? So we are giving cefixime 400 mg. Clear? Second thing is your, if the discharge is coming from the vagina, if the discharge is coming from the vagina, what we can do, we can either it can be candidiasis, either it can be trichomonas, either it can be bacterial vaginosis. Okay, क्या क्या हो सकता है? So candidiasis is a fungal infection, we can use fluconazole, antifungal drug. Okay, candida के लिए drug of choice fluconazole है, so we can use fluconazole 150 mg fluconazole. If it is trichomonas, we can use metronidazole, which is anti-amoebic, anti-protozoal. Okay, if it is bacterial vaginosis, we can also use metronidazole or sakinidazole. दोनों काम करेंगे, right? So kit number 2 बना दिया. Patient is having discharge from the vagina. What you need to do? We need to give the FDC, that is fixed drug combination. What we need to do, उसके अंदर क्या आता है, एक ग्रीन कलर की किट होगी, किट दे दो, किट के अंदर क्या होगा, what will be in the kit, there will be fluconazole 150 mg and sakinidazole 2 gram. So that would be covering the candida as well as trichomonas as well as bacterial vaginosis. तो ज़्यादा अपन को deep investigation की requirement नहीं है. Okay, so we don't need to perform any kind of investigations here. Okay, we just need to give the kit number 2. You are having vaginal discharge, most probably it will be solved, right? Because these are the common infections. Third one is your genital ulcers. We have seen we are having two types of ulcers. फर्स्ट वन इज योर हर्पेटिक अल्सर, हर्पेटिक मतलब हर्पीस, ठीक है, और दूसरा है नॉन हर्पेटिक. सो इफ देर इज जेनाइटल अल्सर विच इज नॉन हर्पेटिक, हाउ वी विल आइडेंटिफाई नॉन हर्पेटिक, बिकॉज इट इज नॉन ग्रुप्ड, हर्पेटिक मतलब ग्रुप. ओके, सो इट इज नॉन ग्रुप्ड अल्सर. ओके, सो नॉन ग्रुप में हम लोगों ने क्या क्या देखा, व्हाट वी हैव सीन सिफिलिस, व्हाट अदर वी हैव सीन डोनोवेनोसिस, वी हैव सीन शैंक्रोइड. शैंक्रोइड वुड बी पेनफुल, syphilis will be painless, and donovenosis will be bifurate ulcer. Okay, that we have seen. So what we need to do, syphilis के लिए drug of choice would be penicillin. In all the cases of syphilis we are using penicillin, except neurosyphilis we are in other cases we are using benzathine penicillin. In neurosyphilis we are not using benzathine. Okay, we are just using penicillin, aqueous penicillin. Okay, so that is the penicillin is a drug of choice for syphilis. For donovenosis and chancroid we can use azithromycin. Okay, donovenosis or chancroid my drug of choice would be azithromycin. So what we have done in the kit number 3, that is white color kit, we have done the penicillin along with the azithromycin. Okay, there are certain people who are allergic to penicillin. In that case scenario, what we have done, we have changed the penicillin to डॉक्सीसाइक्लिन. पेनिसिलिन की जगह क्या किया, टेट्रासाइक्लिन ऐड कर दिया, दैट इज योर डॉक्सीसाइक्लिन, राइट. नेक्स्ट वन इज योर हर्पेटिक. अगर हर्पेटिक है, हर्पीज इज अ वायरल इन्फेक्शन, सो वी नीड टू गिव एंटीवायरल. व्हाट वी नीड टू गिव सर एज साइक्लोविर दे देंगे. कितना देंगे सर, 400 mg TDS 3 times a day into 7 days. Okay, that is your herpetic ulcer. Okay, PID, that is your pelvic inflammatory diseases. अगर किसी को नीचे रीजन में पेन हो रहा है, सो वी कैन यूज सिफेक्सिम अलॉन्ग विद मेट्रोनिडाजोल. सिफेक्सिम इज अ ब्रॉड स्पेक्ट्रम एंटीबायोटिक. metronidazole will be covering the amoebic infections. Okay, if someone is having buboes, there will be lymph nodes. Okay, so in the lymph nodes we can use doxycycline and azithromycin. Okay, so these are the basic STD kits that I have decoded for you. This is what it is written over here. So first one is your, this one is your gray color, this one is your green color, this one is your white, this one is blue, red, yellow, and black. This is the sequence that you should be remembering. So kit number one is for the cervical or urethral discharge. Kit number 2 we have seen for the vaginal discharge. So just remember gray, green, then remember the sequence of Raynaud's, that is white, blue, and red. So white would be non-herpetic, okay, and that blue would be allergic to penicillin, and red will be herpetic, okay, and then we have seen yellow, that is your PID, for PID, and the last one is your black for the buboes, okay. So this is what we have studied. You can see in the PDF, okay. So now let's talk about the vesicobullous disorders. So what are the base vesicobullous disorder? Vesicle का मतलब क्या था? What we have seen, what is the meaning of vesicle and what is the meaning of bulla? वेसिकल मतलब साइज में छोटा है, बुला मतलब साइज में बड़ा है, राइट. सो वी आर हैविंग टू थिंग्स. व्हाट आई हैव टोल्ड यू, हम लोगों ने देखा था देर आर डेस्मोसोम्स एंड देर आर हेमीडेस्मोसोम्स. सो दिस इज बुल्लस पैम्फिगोइड एंड दिस इज पैम्फिगस, okay. So what will happen, what kind of lesions you will see? Let's look here. Okay, so what will happen in vesicobullous disorders? In vesicobullous disorder, we will be studying about the pemphigus. In pemphigus, there will be damage in the epidermis. Okay, problem कहाँ पर होगी pemphigus में? Damage will be in the epidermis because two keratinocytes are bind together in the with the help of desmosomes in the epidermis. Okay, दो keratinocytes we have seen in the epidermis. They are bind together with the help of desmosomes. Okay, now what will happen here? Here what we have seen, the keratinocytes are fine, but there is a problem with the hemidesmosomes, okay. There is a problem with the hemidesmosomes, okay. So look here, pemphigus will be S for, just remember S for superficial, just remember S for superficial, okay. Pemphigus would be superficial, and bullous pemphigoid D for deep, so that would be deep blister. Pemphigus would be superficial blister. Pemphigus would be superficial blister, whereas pemphigoid would be deep blister. Okay. Second thing, antibodies कहाँ बनेगी? Antibodies are formed against desmoglein. Antibodies are formed against desmoglein. Here antibodies are formed against यहाँ पर एंटीबॉडीज किसके लिए बनेगी यहाँ पर एंटीबॉडीज? हियर द एंटीबॉडीज आर फॉर्म्ड अगेंस्ट बुल्लस पैम्फिगोइड एंटीजन 2 more less and BPAG1, okay. BPAG2 और BPAG1 which are basically hemidesmosomal proteins, so यहाँ पर उनके लिए एंटीबॉडीज बनेगी, okay. The most important thing that you should be remembering for the most important buzzword, that would be, here you will be finding tens bulla. Here you will be finding tens bulla, okay. Tens bulla होगा यहाँ पर, and here you will be finding flaccid bulla. Here you will be finding flaccid bulla, okay. Tens क्यों होगा? Because it is in the lower layers, okay. वो नीचे है इसलिए tens है, and this one is above, that is why it is flaccid, okay. Now what will happen? ये देखो, बेसिकली इट इज़ अ स्किन में क्या है? केरेटिनोसाइट्स है, ओके. केरेटिनोसाइट्स क्या है? चिपके हुए हैं. when these keratinocytes will be fell apart, what will happen? There will be rupture of the skin, right? And this is what is pemphigus. क्या हो रहा है देखो यहाँ पर, what is happening? There is basically rupturing of the skin because there is antibody against desmoglein, and if there is antibody against desmoglein, what will happen? There will be, the skin will be fell apart, right? So this is the pemphigus. In pemphigoid, what will happen? There will be problem in the epidermis, then there is basement membrane zone, and then there will be dermis. So there is the problem between these two layers. So what will happen, guys? There will be accumulation of the fluid, and there will be formation of blisters, and that is what is known as bullous pemphigoid. बुल्ला बोल दिया उसको, ठीक है. So this is what you need to remember, okay. In pemphigus we are having pemphigus foliaceus, we are also having pemphigus vulgaris, okay. दो तरीके का pemphigus हम लोगों को याद करना है. First one is pemphigus foliaceus, second one is pemphigus vulgaris. Foliaceus, there will be antibodies against desmoglein 1, okay. Desmoglein 1, F for first, I have told you, F for first, और ये कैसा होगा? ये ऊपर होगा, okay. Foliaceus will be above. सो स्ट्रेटम ग्रेनुलोसम कहाँ पर होगा, स्ट्रेटम ग्रेनुलोसम में होगा। स्ट्रेटम ग्रेनुलोसम के अंदर है तो उसके ऊपर कौन सी लेयर है, कॉर्नियम है। तो वी कैन ऑल्सो कॉल दिस इज ऑल्सो नोन एज सब कॉर्नियल बुल्ला, ये ऊपर होगा, ठीक है। Pemphigus vulgaris, what will happen, there will be antibody against desmoglein 3, antibodies किसके against है, desmoglein 3, and this will be presenting in the stratum spinosum. This will be presenting in the stratum spinosum, so this is known as suprabasal bulla, ठीक है। इसको कौन सा बुल्ला बोलेंगे, सुप्राबेसल। सुप्राबेसल मतलब क्या हो गया, जो बेसल की लेयर है उसके जस्ट अबाव है, सो दैट वुड बी सुप्राबेसल बुल्ला, ओके। Foliaceous will be presenting in the seborrheic areas, whereas vulgaris can include buccal mucosa. This is a very important differentiating feature you can mark. Okay, this is very important differentiating feature that you should be remembering, because buccal mucosa will be affected in the pemphigus vulgaris only. Okay, in pemphigus foliaceous, buccal mucosa will not be affected. Okay, and all the pemphigus group of disorders, they are Minar positive. Minar positive मतलब क्या होता है, Minar positive matlab there will be mucosal involvement, there will be mucosal involvement. They are intraepidermal bulla, intraepidermal bulla. They are intraepidermal bulla. They are Nikolsky positive, Nikolsky positive. I will be telling you what is the meaning of Nikolsky. They are having acanthocytes. यहाँ पर क्या मिलेंगे, acanthocytes मिलेंगे, and there you can see row of tombstone appearance. There you can see row of tombstone appearance. So these are the things that are positive for the pemphigus group of disorders. Pemphigus group of disorders में ये चीज़ें positive होंगी. So what is Nikolsky and what is Absoy-Hansen sign? Nikolsky क्या होता है और Absoy-Hansen क्या होता है, ठीक है। Nikolsky में क्या होगा, when you try to put, just a moment guys, when you try to put tangential pressure, जैसे ही आप tangential pressure लगाओगे तो वो rupture हो जाएगा, that is Nikolsky sign. Absoy-Hansen sign is when you try to put perpendicular pressure to the bulla, it will be spread, ठीक है। These are the two things that you should be remembering, okay। Nikolsky positive, Absoy-Hansen positive, okay। Row of tombstone appearance I have told you, because of there will be so this is the stratum spinosum, this is stratum spinosum. Now what will happen, there will be formation of acanthocytes, okay। ये क्या हुआ, दूर दूर हो गए, दूर दूर होने की वजह से इनकी अपीयरेंस कैसी होगी, that is looking like a row of tombstone appearance, that is looking like a row of tombstone appearance, okay, row of tombstone appearance. When we do direct immunofluorescent, when we do direct immunofluorescence, okay, what you will find, you will find a specific pattern that is known as fishnet pattern. This is very simple. If you try to understand, this is very simple. What is happening here, here I have told you these are two keratinocytes, okay, they are bind together with the help of desmosomes. Now there is a formation of antibodies. कौन सी antibodies बनी, there is formation of IgG antibody against desmosomes, okay, desmosome के against IgG antibody बनी. Now what will happen, wherever you will find, wherever you will find these things, what will happen, there will be deposition of IgG, और उसकी वजह से क्या हुआ, because of that what will happen, the structure will look like a fishnet pattern, right? So because of that this structure is looking like a fishnet pattern because of deposition of IgG antibody, and that is direct immunofluorescent, okay. How you will treat this situation, with the help of steroids, and we can also use cyclophosphamide, okay. So this is the important thing about the pemphigus group of disorders, okay। Now let's talk about the pemphigoid. Pemphigoid में क्या होगा, there will be formation of bulla, ये bulla दिख रहा है, okay, we have already discussed. Here IgG are also formed. What we have seen, IgG here formed against BPAG2 and BPAG1. So IgG are formed against BPAG2 or then BPAG1. Now what will happen, we have seen bullous pemphigoid. Bullous pemphigoid कहाँ पर होना चाहिए, we have discussed, देखो ऊपर क्या होगा एपिडर्मिस, नीचे क्या होगा डर्मिस, between them will be basement membrane zone. So in that basement membrane zone, there will be hemidesmosomal proteins. What are those? We have seen plaquetin, integrin, BPAG2, BPAG1. So these are present in between these two layers. So above will be epidermis, below will be dermis, and that would be basement membrane zone. Okay, और यहाँ पर antibodies बनी है. Here there are antibodies formed against IG, against BPAG2 or BPAG1. So here is the deposition of IgG here. Okay, and that is why it is giving the linear pattern. There is nothing fancy. Okay, so why it is giving the linear pattern over here? Because this is the basement membrane zone, and here we are having BPAG1 or 2, and antibodies are formed against BPAG2 or 1. Clear? Okay, now there is one more disease. Let's see, linear IgG deposition on the basement membrane zone, and here the bulla will be tense. Bulla tense क्यों होगा? Because वो नीचे है. Okay, flaccid bulla will be seen in the cases of pemphigus. क्वेश्चन में flaccid bulla दे रखा है, आंसर pemphigus कर देना. ठीक है, और उसके साथ में what other thing, अगर क्वेश्चन में दे रखा है, अगर क्वेश्चन में म्यूकोजल इन्वॉल्वमेंट दे रखा है तो आंसर क्या कर देना? वल्गेरिस कर देना है, फोलिशियस नहीं करना है. ओके, सो दिस these are the buzzwords that you should be remembering, that will help you to solve most of the question. Remember, this is not very tough, you can always do it. Okay, so tense bulla, just remember tense bulla will be bullous pemphigoid. Okay, treatment will be steroids. Linear IgA disease, one more disease is there which will be showing such kind of immunofluorescent pattern. Here IgA will be deposited on the basement membrane zone. यहाँ पर कौन सी चीज़ डिपॉजिट हो रही है? IgA. यहाँ पर क्या डिपॉजिट हुआ था? IgG. That is what you need to remember. So linear IgA disease, what will happen? There will be deposition of IgA antibody. Okay, drug of choice we can use dapsone, and in linear IgA disease we will see a structure that is known as string of pearl appearance. Okay, यहाँ पर क्या मिलेगा? String of pearl appearance मिलेगा. Okay, apart from this we are going to move on to dermatitis herpetiformis. We are going to move on to dermatitis herpetiformis. So dermatitis herpetiformis is associated with a disease that is known as celiac disease. Celiac disease. Okay, and it is associated with certain HLAs, that is very important: HLA-B8, HLA-DQ2, HLA-DR3. Okay, and it is associated with three antibodies, that is anti-endomysial antibody, anti-endomysial antibody, anti-gliadin antibody, okay, and anti-TTG antibody. So we are having anti-endomysial antibody, we are having anti-gliadin antibody, and we are also having as anti-TTG, that is tissue transglutaminase antibody, that we can do for the celiac disease as well as dermatitis herpetiformis. In dermatitis herpetiformis, there will be formation of grouped vesicle. There will be formation of grouped vesicle on extensor surface. So these are the extensor surface, and they are having the grouped vesicle. Remember, we have already studied grouped means herpetic, that is why it is dermatitis herpetiformis. Okay, dermatitis means inflammation, herpetiformis means there will be grouped vesicle, okay, over extensor surface. Okay, there will be grouped vesicle over extensor surface. What else you can see? This is your basically papillary. What we have seen in the micro abscesses we have already discussed, so that would be papillary tip micro abscess. That would be papillary tip micro abscess that we will be looking in the cases of dermatitis herpetiformis. Okay, that is papillary tip micro abscess. Okay, so this is रेटरिजस जो नीचे जा रहा है, and whatever is coming up, that is your papillary tip. How you are going to treat this situation? What is the drug of choice and what is the treatment of choice? So the drug of choice will be, we can use dapsone, and the treatment of choice, we need to avoid the cereals, that is bro, that is barley, rye, oats, and wheat. We need to avoid that in the cases of celiac diseases. Okay, celiac disease. So this is important about the dermatitis herpetiformis. This is important about the dermatitis herpetiformis. Now let's move on to pigmentary disorder. Now let's talk about the pigmentary disorder. So first one, what is this? What is this, guys? What you are seeing here? This is the case of melasma or cloasma, because of the excessive deposition of, this is happening due to excessive deposition of melanin. Due to excessive deposition of melanin, what will happen? There will be changes in the color. There will be increase in the color changes. Okay, this one is your Mongolian spot. This can be asked from pediatrics also. This is your Mongolian spot, generally seen on the back of the baby, back side of trunk, generally seen on the back side of the trunk, and it is a self-resolved condition. It is a self-resolved condition, guys. So it will be self-limiting in how much time it will be cured. That is approximately 1 year. It will be resolved within a year. Okay, this one is your nevus. The meaning of nevus means the change in the color. Okay, so that would be nevus of ota. Okay, so there will be bluish discoloration. There will be discoloration bluish discoloration of eye around the ophthalmic region. Okay, यहाँ से यहाँ तक. So that is nevus of ota. Here you can see acanthosis nigricans. Basically this is the thickening of stratum spinosum. Thickening of stratum spinosum. Remember, we have done this layers. Okay, so there will be thickening of stratum spinosum, and that is known as acanthosis nigricans. Acanthosis nigricans. Or this is a marker for multiple things. This can tell us about multiple things. Okay, so this is a marker for internal malignancy. It can tell us about the internal malignancy. This is a marker for internal malignancy. Apart from that, it can be telling us about the diabetes mellitus. It can be telling us about the diabetes mellitus and certain other diseases also, like gastric carcinoma also. Okay, this one is your nevus of Ito. Here you can see bluish discoloration over the acromioclavicular joint. Okay, or shoulder के आसपास bluish discoloration, that is known as nevus of Ito. Okay, this one is your Baker's nevus. Baker's nevus में क्या होगा? There will be discoloration and there will be hair growth on that discoloration. Okay, so there will be discoloration along with hairs. Discoloration along with the hairs. That is your Baker's nevus. Okay, so now we are done with the pigmentary disorder. Let's talk about certain miscellaneous topics. Okay, so the first one is your identify the situation, guys. What is it? Melanocytes are absent, and here you will find the very characteristic finding, that is white forelocks. White forelocks is a very characteristic finding that you are looking here, and this is a case of pyabaldism. This is a case of pyabaldism. Pyabaldism किसको हुआ था? You have seen this in the. This is basically a autosomal dominant condition. Pyabaldism is a autosomal dominant condition. What will happen? There will be absence of melanocytes. I have already told you melanocytes are absent, so there will be no melanosome formation. And if there is no melanosome formation, what will be? There will be no color to the adjacent keratinocytes. If there is no color to the adjacent keratinocyte, what will happen? There will be discoloration. There will be abnormal color, right? So that is a melanocyte absent. Okay, second thing is your vitiligo. Vitiligo can be of two type. It can be localized, it can be generalized. Okay, here also there will be absence of melanocytes. In localized, what will happen? It can be focal vitiligo. That means certain areas are having vitiligo. Okay, that can be focal vitiligo, or it can be segmental vitiligo. Segmental में क्या होगा, that would be along a nerve segment. Okay, vitiligo होगा that would be along a nerve segment that is localized. In generalized, what will happen, it will be seen in both the sides. Both the sides, generalized वाला जो होगा that would be seen in the both the sides. Okay, so here we can have acrofacial, that means it will be on the extremities, it will be on the extremities and on the face. Okay, vulgaris means the most common type of vitiligo. Okay, vulgaris का मतलब होगा most common, and universalis means most of the body is covered with the vitiligo. Remember, when vitiligo is affecting the hairs, okay, that would be having the very bad prognosis. Okay, worst prognosis you can say. So that is about the vitiligo. let's talk about the let's talk about this situation, that here this situation is albinism. This situation is albinism, and here there is a problem in melanogenesis. Melanin नहीं बन रहा. Okay, melanin कहाँ से बनता है? Which from biochemistry, tell me which amino acid will be helping you guys to form melanin? कौन सा amino acid melanin बनाता है? So remember guys, there is amino acid that is tyrosine जो होता है amino acid, that would be forming your epinephrine, norepinephrine, dopamine along with that melanin. Okay, so there is an enzyme tyrosinase. There is an enzyme tyrosinase. So tyrosinase अगर absent है, tyrosinase में problem है, that will lead to a disease that is known as albinism. क्योंकि tyrosinase नहीं है तो how you will make the melanin, and if there is no melanogenesis there will be no melanin, so that patient or the person will look like this. Okay, there will be no color discoloration. Okay, all right. Next thing is your, so remember one more thing, albinism is a autosomal recessive condition. Albinism is a autosomal recessive condition. Okay, now look here guys, which is this cell? This is cerebriform this is cerebriform nucleus, or this is cerebriform nucleus, or Sézary cells. Sézary cell will be seen in which from your patho you must have studied this. So this is your cutaneous, basically this is your cutaneous T cell lymphoma. This is basically your cutaneous T cell lymphoma. Okay, cutaneous T cell lymphoma, also known as mycosis, fungoides. And what is the type of microabscess that we have seen over here? Remember guys, M के साथ में P आएगा, M के साथ M नहीं आएगा, so that would be Portier's microabscess. Okay, so that would be Portier's microabscess. Identify this image. This is the image of Harlequin baby. This is the image of Harlequin baby. And what is the thing that is mutated over here? That is, what is the gene that is mutated over here? That is ABCA12. The gene that is mutated over here will be ABCA12. Okay, which is this test guys? This has been asked. This is patch test. And this is done for the identification of allergy. Okay, this is done for the identification of allergy. This is a patch test. Okay, this is a patch test, and reading will be taken in 48 to 96 hours. Okay, generally we take 96 hours. 48 to 96 hours reading will be taken. It is a type 4 hypersensitivity. Okay, this one is your herpes मतलब क्या था? That is the meaning of grouped vesicle. And zoster का मतलब होता है herpes zoster. The meaning of zoster is along a nerve segment. Okay, so herpes zoster is nothing but there will be grouped vesicle along a nerve segment. Clear? Okay, so this is the case of herpes zoster. And how we are going to treat herpes zoster? Is a viral infection. So how we are going to treat? We are going to give acyclovir. How much? We are going to give 800 mg into 5 times a day into 7 days. Okay, so this is how we are going to treat the herpes zoster. Okay, this one is your dermatomyositis. Okay, dermatomyositis, what is written? Derma means skin, myo means muscle, itis means inflammation. Okay, so there will be look here, there will be heliotrope rash. What is heliotrope rash? It is erythematous erythematous edematous erythematous edema around the eye. That is what is known as heliotrope rash. This is known as heliotrope rash. Okay, we are also having shawl sign. Shawl sign क्या होगा? Where we pull over the shawl, जहाँ पर shawl ओढ़ते हैं, that is the place where we are having uh, erythema. Okay, that is the place where we are having erythema, and that is why it is known as erythematous lesions over the area where we pull over the shawl. Okay, so that is the shawl sign. Okay, third one is your these papules. Okay, look here, these are your Gauthron's papules. Gauthron's papules. Okay, these are basically papules at the MCP, papules at MCP, and there will be thickening, there will be thickening, there will be thickening of, there will be thickening of, there will be thickening of stratum corneum. In this condition, what will happen? There will be thickening of stratum corneum, and that is what is known as Gauthron's papule. Okay, so this is the triad for dermatomyositis, has been asked before in your examination. Very important, guys. Okay, so this is shawl sign, this one is your heliotrope rash, and this one is your Gauthron's papule, right? Mechanic hand because of thickening of the stratum corneum. Mechanic hand because of thickening of the stratum corneum, right? This one is your SSSS, staphylococcal scalded skin syndrome. Now what will happen? There will be formation of certain toxins. This is due to staph bacteria, so there will be exfoliative toxin. What toxin? There will be exfoliative or epidermolytic toxin. Epidermolytic toxin type 1. This is due to epidermolytic toxin type 1, or this is due to exfoliative toxin type 1. Okay, this will be causing exfoliation in the skin, you can see here. Okay, so this is basically staphylococcal scalded skin syndrome. Okay, we are having one more thing, that is toxic epidermal necrolysis. Okay, this is generally due to anti-epileptic drugs. This is generally due to anti-epileptic drugs or antipsychiatric drugs that we are using. That is your phenytoin, lamotrigine. Okay, this can be due to NSAIDs as well. So basically this is 10. Okay, toxic epidermal necrolysis. One more entity is there, that is Steven Johnson syndrome. Steven Johnson syndrome and 10 are basically due to same reasons. Okay, their reasons can be same, but and the main difference is in Steven Johnson syndrome, there will be less than 10% of the area is covered, and in here there will be more than 30% of the area will be damaged. Okay, so if it is less than 10%, that we call it Steven Johnson syndrome. If it is more than 30%, we call it toxic epidermal necrolysis. Okay, along with that, if it is in between, we call it overlap. अगर दोनों के बीच का है, then we call it overlap. Okay, then we call it overlap. Now let's talk about the skin cancers. Okay, we are having different type of skin cancers. First one is your basal cell carcinoma. Basal cell carcinoma, also known as rodent ulcer, also known as rodent ulcer. Okay, this one is also known as rodent ulcer. कहाँ पर होगा? Near the teardrop. Okay, इस वाले region में होगा. That would be in the region of teardrop region. Okay, ये this one will be not this is not so likely to spread. This is the least likely to spread. Okay, ये जहाँ पर होगा वहीं होगा, and if you will excise it, okay, if you will excise it, then it is treated. Okay, so it is easy to treat, easy to treat. Just remove this, just remove this, and that would be treated. Okay, so this is your rodent ulcer or basal cell carcinoma around the teardrop region. Okay, and it is very easy to treat, and it will not metastatized. Okay, so that is the basal cell carcinoma. Second one is your squamous cell carcinoma. Squamous cell carcinoma, it is firm red pimple, it is firm red pimple nodules or scaly patch, you can see. Okay, this is more severe as compared to basal cell carcinoma. Okay, this can spread, this can spread, and if it is find in the early stages, that can be treated. Okay, in the early stages, that can be treated well. Okay, this one is your malignant melanoma. Malignant melanoma is a dangerous situation. Okay, this is most serious form, and it needs to diagnose early, and it needs to treat early, because it will be spreading very fast. It will be including other organs, and they will be providing other meds. Okay, so they will be giving rise to other cancers as well. Okay, so that is what is your melanoma. Okay, so these are the three important things. We need to differentiate between a melanoma and a mole. Okay, now we will see how we will differentiate between a melanoma and a mole. Okay, this one is your xeroderma pigmentosum. Xeroderma pigmentosum is nothing but a nucleotide. This is a nucleotide excision. This is a nucleotide excision repair defect. This is a nucleotide excision repair defect. This is basically a nucleotide excision repair defect. Okay, here the patient cannot go out. Xeroderma matlab what will happen, there will be dryness in the skin, and the patient cannot go out in the sun, and they are more prone to like different kind of cancers. They can have squamous cell carcinoma, they can have melanomas. Okay, so these patients are at a risk, and this is a nucleotide excision repair defect. That is what is important for you to remember about this. Okay, now next one is your, this one is a lupus pernio, or that you will see in the cases of sarcoidosis. Okay, so here what will happen, it will be including the nasal breeze as well as the other parts. Okay, it will not spare the nasolabial fold. Then what will spare the nasolabial fold, that is your butterfly rash. Okay, butterfly rash will be seen in the SLE, and that would be a differential for the lupus pernio. Lupus pernio में क्या होगा, there will be redness all around. Okay, it won't spare your NLF, but but SLE will be SLE will be SLE will be sparing, SLE will be sparing your nasolabial folds, right? So this is SLE, and this one is your lupus pernio seen in the cases of sarcoidosis. Okay, this is your Raynaud's phenomena. Raynaud's phenomena, what will happen, there will be the color sequence, that is white, then there will be blue, and then there will be red. So white is due to vasoconstriction. What will happen, because of vasoconstriction the blood supply will not get there, and due to that what will happen, there will be ischemia, and due to ischemia there will be pale color or white color. Okay, now what will happen, because of white ischemia, what will happen, there will be cyanosis, and you remember cyanosis is blue color. Okay, so there will be cyanosis, and that will be giving rise to blue color. After that what will happen, there will be regain of the normalization, or normalization of the vessels, and that would be leading to the red color again. There will be restoration of the blood supply. Okay, so this is the Raynaud's phenomena. Raynaud's phenomena can be seen with multiple diseases, multiple things, you can say sclerodactyly or scleroderma, which is a systemic sclerosis. You can also see over there. In this situation, what will happen? This can be due to hot and cold phenomena as well. Okay, so extreme hot or extreme cold can also precipitate this situation. Okay, like we have discussed, scleroderma is a, in scleroderma what will happen, there will be you can see sclerodactyly. Okay, what is the meaning of sclerodactyly? There will be pitting with scarring ulcers. Okay, pitting hoga, or pitting, along with the pitting there will be scarring ulcers. Okay, so that would be seen in the cases of scleroderma or systemic sclerosis. Okay, that you will study in the pathology. Okay, this one is your pyoderma gangrenosum. Pyoderma gangrenosum, the question that has been asked in the previous examination, that it is associated with which inflammatory bowel disease. So in inflammatory bowel disease, we are having Crohn's disease, we are having ulcerative colitis. So it is associated with ulcerative colitis. So it is associated with ulcerative colitis. Okay, in ulcerative colitis you will see multiple things, lead pipe appearance, all those things. Okay, so we will be discussing that in the later part. Right now, just look here. So this is your dermatitis. Let's talk about certain dermatitis, miscellaneous dermatitis. So these are your allergic contact dermatitis. First one is your allergic contact dermatitis, and this is due to nickel. Because in female what will happen, they will wear the anklet पहनते हैं, पायल जो भी है, and they are made up of ornaments, they are made up of nickel, and nickel has a nickel will act as a allergen. Okay, and that is why it is giving rise to dermatitis. Okay, and here it is atopic dermatitis. Atopic dermatitis, it can be seen in the cases of hay fever. This is basically type 1 hypersensitivity. Atopic dermatitis is type 1 hypersensitivity, whereas this contact dermatitis will be type 4 hypersensitivity. Okay, next thing, irritant contact dermatitis, that can be due to irritants like people can use detergent and all those things. Okay, neurodermatitis, that would be along with the nerve segment again. Okay, perioral dermatitis, that is around the oral area, and this one is your seborrheic dermatitis, that would be seen in the seborrheic areas, like uh, that is basically dandruff. Okay, so this is also a seborrheic dermatitis, and here you can see all the flags. Okay, in children you can see cradle cap appearance, that is also a type of seborrheic dermatitis. Okay, astiotic or winter eczema, we have already seen, that is due to decrease in the levels of lipids, and that would be causing xerotic, means there will be more dryness, and that would be causing itching, that is dermatitis. Okay, next one is your nummular dermatitis. Basically the meaning of nummular will be coin shaped lesion. यहाँ पर lesion कैसा होगा, the lesion will be coin shaped lesions. Okay, so the lesions will be coin shaped over here, and this is the test, again the patch test that we are doing for all the investigations, that is your patch test, and that reading will be taken 48 to 96 hours. We can take the best answer would be 96 hours, we can take up 48 hours as well. Okay, so these are certain important allergens and sources that are causing the dermatitis. So in artificial jewelry, jeans button, what we are having, we are having nickel, cobalt. Okay, in cement we are having potassium dichromate or chromium. In paint we are also having potassium dichromate. In plants we are having that is parthenium or congress grass, you can say. Hair dye, you are having ppd. Topical medicines like neomycin can also cause dermatitis. In the gloves we are having, some people are allergic to latex or rubber. And in bindi we are having ptbp, that is para tertiary butyl phenol. Okay, so these are the important things, this is the important table that you should be remembering. And this one is the abcde rule for early detection of melanoma. So how you are going to decide between a melanoma and a mole? Okay, कैसे पता चलेगा that it is a melanoma and it is a mole? So you need to this is the question that has been asked. So you need to have abcde classification. So A means asymmetry, B means border. So melanoma will be asymmetrical. Okay, melanoma will be having uneven borders. Okay, इसकी borders कैसी होगी, uneven होगी. It will be having different color. Melanoma will be having color that would be different, it will be changing the color. The diameter will be more than 6 mm. Okay, and it will be changing the size, it will be changing the size. Okay, it will be changing the size, it will be increasing in the size. Okay, so this is what you need to remember about the melanoma. Okay, thank you so much guys for all the patience that you have given me. Okay, and if you have any doubts, you can always reach out to me on my Instagram. You can reach out to me on my Instagram, or you can reach out to me on my Telegram. Okay, that is so. I hope you guys have understood all the things, and please try to do PYQs along with this, so that you can be having you can if you are having then any doubts, you can ask me, and I will be more than happy to solve all the questions that you are having, and I would be more than happy to help you. Okay, thank you so much guys for all the patience, and if you are having any doubts, do ask now. I will be answering.